Good afternoon. This is Tuesday, September 7th of 2021. We are onward and upward into our last week of new material before our first exam. So like I said, when the schedule gets shorter, it always gets scarier. We are going to finish up our discussion of blood vessels today and then start a discussion of blood anatomy. And then from there, we will finish that up on Thursday. Also on Thursday, you've got 3 more assignments due, 2 lab simulations, and then 1 more unit review. We have stayed good on schedule, so I anticipate Thursday's lecture will not take the whole class, which means we should have the opportunity for a review for this first exam. Now, when I say a review, I do not mean me standing here telling all of you what I think are important. After all, that is what I do every day in class. What I mean by review is that you ask questions about the material or concepts that you're not clear on, or equations that you don't understand, or something that you need assistance with. And we will work through that information together to make sure that you understand it. So make sure you come with questions on Thursday. If nobody has any questions about the material on Thursday, then I assume that you've all mastered the material. I have no problems with the material, and I make the exams harder. So make sure you come with questions so that we can make sure that everybody gets the grade they want on this exam. And that is what you'll be doing on Tuesday. Again, I know we have a classroom set up for Tuesday, but again, we're not meeting. All you're doing on Tuesday is taking those 2 exams. And we've talked about that process. So hopefully you understand what is expected of you for that. We did that in the last class, and that's all you'll be doing on that day. Also, hopefully at this period of time, you realize that it is always important to be here in class. You get the information, you get to ask questions, you get to be active in the learning process, and that is vitally, vitally important. This is a synchronous class, and it is important to be here. But it is going to be particularly important to be here on Thursday after the exam. I know there's always a little bit of a hangover after an exam, and there's especially with the lectures being recorded, there's an inclination to want to sleep in or recover from your hangover and not be here and just watch it at your own leisure. However, on Thursday, we are going to be forming groups, and you are going to be selecting topics for a group presentation that you will be doing that will be worth 50 points of your grade in this next section. And you must be here on Thursday to be added to a group. You must be here on Thursday so your group can pick a topic. And if you are not here and not part of a group, then you are automatically getting a 0 on this assignment. So it is vitally, vitally, vitally important you are here on the 16th. If you already know there's a conflict on that and you won't be here on the 16th, then you need to email me immediately so we can make arrangements for that. Because if you do not contact me and you do not show up on Thursday, you will not be in a group. And if you are not in a group, you will not have the opportunity to participate in this activity, and you will get a 0 out of 50 on this assignment, which is something you do not want. All right. Questions on any of that? All right, you guys have all gotten so quiet in this class. You're the second semester class. You should be more active than this. All right, hopefully all of that makes sense then. And if there are no questions, we will move on to our lecture.
Actually, Professor, I have a quick question.
Yes.
For the list of topics that you're talking about, is it already up that we can look somewhere, or will you be giving it to us on the day?
Neither. It is not already up, but it will be something that you as a group will work on together, and then will then ask me, and we will approve that. Again, it's only going to be 1 topic per group. So you guys pick your assignments as a group. You decide what topic it is. I find it is not convenient for me to give you a topic. I find students are much more active in the learning process if it is something that is of interest to them. So you get to pick your topic. I will be randomly assigning you to groups. So you don't get to pick your groups, but you do get to pick your topic. But it's something we will be doing on Thursday. And again, that's after the first lab and lecture exam. So there is literally nothing you have to do to prepare for that ahead of time. So I would put it out of your mind and focus just on the exam between now and Tuesday.
Awesome. Thank you.
All right. Excellent. All right. I know I say presentation and everybody panics. Nobody likes to talk in front of a group. And I appreciate and understand this, but this is very low key, even though it's worth 50 points. It is important point wise, but again, you're being graded on your content, not on your presentation skills. Obviously, you're going to be on Zoom, so you don't even have to be wearing pants while you do it. So it's about as low key as it possibly can be, but it is important. So it is important to be here. And again, hopefully you figured out it's important to be here every day anyway. All right, great question. Any others? All right, perfect. Then let's go ahead and get started. We left off last class and we were talking about this concept of blood pressure and the differences in the pressures of the blood when the blood is being ejected from the heart and when it is not being ejected from the heart, and how to measure it. And we, in very broad strokes, talked about some of the numbers that may be good, some of the numbers that may be bad. But as we also talked about, obviously, it is going to be important to maintain your blood pressure. And as we just finished talking about in the last class, there are basically three main factors that modify and change blood pressure. The first is our cardiac output. Of course, our cardiac output is a measure of the amount of blood put into the blood vessels. And as we've talked about, the more stuff you put into those blood vessels, the more they're going to bounce into the walls, and therefore the higher the blood pressure is going to go. So again, as cardiac output increases, what effect does that have on blood pressure?
Increases.
Yeah, it increases. Excellent. Excellent. Peripheral resistance. As we talked about, peripheral resistance is basically the friction that the blood has as it is passing through the blood vessels. And while we talked about several factors that influence peripheral resistance, what was the primary, or at least the dynamic, the changeable from moment to moment factor that influences our peripheral resistance?
Diameter.
Radius.
Yeah, exactly. It's affected by the diameter, or really the radius, you guys are absolutely right, of the blood vessels. Excellent. And again, let's think about this. As therefore the radius decreases, what effect does that have on resistance?
Increase.
And as that resistance increases, as the radius decreases, what effect do you think that has on blood pressure?
Increases.
Increases as well. Excellent. Spectacular. Lastly, obviously, the total number of total volume of blood, the total number of things you have pushing on the wall, right? Blood that you have in the blood vessels. And of course, when blood volume increases, what effect does that have on blood pressure?
Increases blood pressure.
Increases as well. Excellent. So we see these relationships of these factors. And are these things that we are able to control, that we are able to modify? Can we modify cardiac output? Can we modify peripheral resistance? Can we modify blood volume?
Yes.
Yeah, absolutely. Right. And so absolutely we can do that. In fact, we have a direct relationship between blood pressure and these factors. So blood pressure is actually equal to our cardiac output times the peripheral resistance of our blood vessels. So again, that's a direct measure there. And also there's a direct relationship between, as we talked about, the blood volume is basically the amount of stuff that there is to bounce against the walls. And the more something bounce against the walls, the more pressure. So the amount of stuff is directly related to the pressure of the blood as well. So anything that changes those three factors can influence our blood pressure. Now, as we know, there are some neural controls for this. Again, they start in the medulla. And what are the two main pathways again?
Sympathetic and parasympathetic.
I'll take that for now. Sympathetic and parasympathetic. Although let's be a little bit more specific. We'll start easy. What is the primary pathway of the parasympathetic nervous system to the heart?
White ramus,
I'm sorry?
or like the white matter. To the brain.
Sort of, yeah. What's the pathway? What's the primary way that the parasympathetic nervous system sends signals to the heart?
Vagus nerve.
Vagus nerve, exactly. Which cranial nerve? 10, right? The vagus nerve. Excellent. Excellent. And someone remind me again, what parts of the heart the parasympathetic nervous system actually communicates with?
The SA node and AV node.
Node. Excellent. Remind me again what neurotransmitter releases?
Acetylcholine.
Acetylcholine.
Excellent. And what is the effect?
Inhibitory.
Okay, but what does that mean specifically when we're talking about the heart? When you're inhibitory on the SA and the AV node, what happens to the heart?
Slower heart rate.
Excellent.
Slower heart rate.
The heart rate
Decrease.
decreases. And which of our three factors that affect blood pressure is influenced by a decrease in heart rate?
Cardiac output.
Cardiac output. And what effect does a decreased heart rate have on cardiac output?
Decreases the cardiac output.
Excellent. And then, so therefore, what effect does that have on blood pressure?
Decreases blood pressure.
Right. Now notice this is kind of an indirect pathway for an influence on blood pressure. And sympathetic nervous system also has an indirect pathway for this as well. We'll go easy. What nerves, pardon me, what do we call the postganglionic axons in the sympathetic pathway that innervate the heart?
Purkinje cell.
No, those are one of the things of the heart that is affected, but what do we call the sympathetic axons that are traveling to the heart? What do we call them? Anybody knows? This is actually an easy question. It's not the vagus nerve. What
Cardiac
nerve is?
nerve.
Not a bad guess. Cardiac nerve would be correct. I was actually looking for something more generic, and the more generic is actually just sympathetic nerve. Oops, I don't have any idea where I'm writing. There we go. So they're basically just sympathetic nerves. Remember, it's the sympathetic nerves coming out of the chain ganglia, specifically the middle or inferior chain, cervical chain ganglia. And again, for right now, we'll just worry about those sympathetic nerves that come out. And as we talked about, they also connect to the SA node and to the AV node. What neurotransmitter do they release?
Epinephrine and
Epinephrine, norepinephrine.
Well, remember, the axons themselves release norepinephrine. Epinephrine, remember, is released by the adrenal gland, and it will have the same effect, but it isn't necessarily released from the sympathetic nerves. So you guys are right. Epinephrine is released by the adrenal gland. It has the exact same effect, but the nerves themselves just release norepinephrine. And what is that effect?
Excitatory.
Excitatory, speed up.
Excellent. Heart rate increases. Oh, that's
Doesn't
right.
stroke volume also increase?
Well, we'll get to that.
Okay.
Stroke volume increases. Oops.
Blood pressure increases.
Well, hold on. Heart rate increases. So what does that directly affect?
Increased cardiac.
Exactly. Our cardiac output increases. And as our cardiac output increases, what happens to our blood pressure?
Increases.
Increases. And again, Notice the direct effect is on the cardiac output, not directly on the blood pressure. So as we talked about, this is another indirect pathway. However, you guys have hit it on the head. The other point that we know is that our sympathetic nervous system also innervates the Purkinje fibers. And again, those also, we're going to release norepinephrine. What's the effect?
Increased stroke volume.
Excellent. I like that. We have an increased stroke volume, which influences what?
Cardiac output
Increases or decreases it?
increase with an increase of blood pressure.
Excellent. Which also is an indirect effect. But there's one other thing that our sympathetic nervous system innervates. What else does our sympathetic nervous system innervate that our parasympathetic doesn't?
Strength of contractions.
Well, but that's what we got there from the Purkinje fibers. That gave us that increased stroke volume. That gave us that increased strength of contraction.
Is it the preload or post load or after load?
Again, by making it beat harder, we are affecting that stroke volume, and that does that. But what is another structure outside of the heart that could affect blood pressure that is also innervated by the sympathetic nervous system?
The smooth muscles of blood vessels.
Vessels.
Bingo. It innervates the smooth muscle of our blood vessels. Now, yes, we know that it releases primarily norepinephrine. There are some exceptions to this, but primarily norepinephrine. And as we talked about in 430, does it affect every single blood vessel in our body the same way?
No.
No. Blood vessels to the heart, blood vessels to the lungs, blood vessels to the livers and the skeletal muscle dilate. However, blood vessels to other areas like the skin, like the digestive system, stuff like that decrease. So we have some increasing and some decreasing. However, overall, if we take all the blood vessels in the body together, what is the main general effect? Is it in general increasing or decreasing blood vessel size?
Increasing.
Well, do you think it's moving blood away from more areas or moving blood to more areas?
Just moving it to muscles and things you need to use. So I guess it'd be
True,
moving it.
but so think of it this way. Do you think when you're in that fight or flight situation, do you think there's more things that you need to use or more things that you don't need to be using?
Oh, don't need to be using.
Exactly. So in general, it constricts overall. The overall effect is that it constricts blood vessels. Decrease in diameter. And if it's decreasing the diameter, what is the direct effect of that?
Increase in blood pressure.
Yeah, it increases blood pressure. So notice the sympathetic has a much greater effect on blood pressure than our parasympathetic does. Because not only does it affect the SA and AV node that affects the heart rate, but it can affect the strength of the contraction by innervating the Purkinje fibers, all of which affect cardiac output, which, as we know, affect blood pressure. But we can also think of it as in this direct effect by actually changing the diameter of the blood pressures themselves, something that our parasympathetic nervous system can't do. If you think about it, there's really no new information on the board right now. We are just, again, summing up information that we've already talked about in this class and reemphasizing it to make sure that we understand it. So hopefully we are comfortable with this neural control that we've talked about for our cardiovascular system. And now we're just using that information we've already talked about to now think about how it is both directly and indirectly affecting our blood pressure. All right. So we have that, we did that, we did that. But what we haven't talked about is, again, what is the stimulus for this control? Yes, we know how the sympathetic nervous system and parasympathetic nervous system can influence and modify blood pressure, but we haven't talked about what the stimulus are, what the triggers are. And the two primary triggers are going to be chemoreceptors and baroreceptors. Chemoreceptors are going to be looking for things like the pH of the blood, or it's going to be looking for the oxygen, the partial pressure of oxygen in the blood, or things along those lines. It's going to be looking for factors influencing or indicating activity or stress or things along those lines that can influence and modify blood pressure. But one of the big factors that allows us to make dynamic changes to our blood pressure are baroreceptors. Baroreceptors do what? What do baroreceptors measure?
Pressure.
Exactly. They measure blah, blah, blah. They measure pressure. Let's talk about this baroreceptor reflex and exactly how this would work. And let's use the whiteboard for this. All right, we have blood vessels. And inside of those blood vessels, we have blood. And that blood is always pushing against its boundaries. Actually, let's change that. Inside of our blood vessels, we essentially have these stretch receptors. And these stretch receptors are measuring how much the smooth muscle is stretched out.
They're like the same kind of receptors in like your stomach.
Yep, exactly the same type of stretch receptor. Well, very similar stretch receptors, yes, but you've absolutely got the right idea. And so notice, because of this, they are constantly firing action potentials. All right, so far so good?
Yep.
So let's think of an imbalance. Let's say we have an imbalance where there is an increase in blood pressure. We have our blood vessel. With the blood inside of it. Oh, don't need that caps. With the blood inside of it. And the blood pressure goes up. What happens to the force of the blood on the walls when the blood pressure goes up?
Increases.
Absolutely, excellent. So we get this increase of force on the blood vessel. And of course, that increase in force causes our blood vessel walls, because of the elasticity in them, to stretch. So as a result of this, the blood vessel stretches. Because of this increased blood pressure. And when that happens, what do you think happens to the firing rate of the baroreceptors?
Increases.
Yeah, the baroreceptors are going to increase their firing rate. So now we have this increase in firing rate, which we have to send to some, command center. And as we just finished talking about, our command center are those cardiac nuclei located in the medulla. And so as a result of this, we are going to get one of two effects, right? We want to do two things to bring the blood pressure down. Our goal, and let's think of that this way, we'll work our way back. Our goal is twofold, right? What are some of the ways that we could bring the blood pressure down?
Vasodilate.
Exactly, excellent. Our goal is to bring the blood pressure down. And you're right, there are two ways to do that. One thing we can do is we can cause the blood vessel to dilate. Excellent. Now that we know how to do that, and now that we know what we want to do, obviously our effector is going to be the smooth muscle of the blood vessel. So how are we going to get that smooth muscle of the blood vessel to dilate?
Can we increase acetylcholine levels?
But remember, as acetylcholine, does our parasympathetic nervous system really affect the blood vessels directly?
No.
In this case, we want to send a signal. We need to send a signal to the blood vessels directly. What allows us to send a signal to our blood vessels directly?
Epinephrine.
Well, our sympathetic nervous system, absolutely. So with our sympathetic nervous system, we know normally when it releases its chemical, it causes the blood vessels to normally constrict. So what would we want to do to the activation of our sympathetic nervous system? Do we want to increase it or decrease it?
Decrease.
There you go. We're going to decrease activation of the sympathetic nervous system. With less activation, our smooth muscles are going to dilate. And when our smooth muscles dilate, as a result of that dilation of the blood vessel, we get a decrease in pressure. Because as we know, in this case, we have a set amount of stuff inside of the blood vessel. So when the blood vessel gets bigger, what happens to the amount of times that the blood is going to bounce into the walls?
Unless.
Yep. Excellent.
How do you decrease the activation of the sympathetic nervous system?
You stimulate it less. Also, it tends to be antagonistic. So one of the things we can do to decrease sympathetic is we can also increase our parasympathetic. This does not affect the blood vessels, but it has an antagonistic effect on the sympathetic nervous system. So we get it to fire less.
So to decrease activation would be to do something active to decrease,
Yes.
like taking a nap. Or
closing your eyes and I mean, yes. So again, when you
killing
take a
the
nap,
bear with an axe.
you are not consciously lowering your sympathetic nervous system, right? That isn't something you can consciously do. We can sort of keep around it. Like if, for instance, if you meditate, you put yourself into a state where your parasympathetic nervous system activation tends to be higher than your sympathetic, but you're not turning it on and off like a faucet or voluntarily controlling it the way you're moving the muscle in your body, right?
It would be just kind of like overcoming whatever is causing the increase in blood pressure.
Well, no, in this case, really what it comes down to is there are all these nuclei, all these neurons in the nuclei of the medulla that can increase or decrease their rate of activation that can have an inhibitory or an excitatory effect on the sympathetic nervous system. So here in the medulla is where we are counting our beams to decide whether we want to increase or decrease our sympathetic nervous system output. And in this case, we want to decrease the output. Now, let's take it one step forward. This decrease in output of the sympathetic nervous system, is it going to have another effect?
Yes.
What? What's another target of the cardiovascular system for the sympathetic nervous system?
Gonna decrease heart rate.
Yeah, and not just a decrease in heart rate, but also a decrease in what?
Stroke
Blood
volume.
flow. Stroke volume.
Right, in strength of
Cardiac
contraction.
output.
Right, exactly. Strength of contraction. Both of these are going to lower, as you mentioned, our cardiac output. And as our cardiac output goes down, what happens to blood pressure?
Blood pressure goes down.
It goes down as well.
Yeah, I guess I was just thinking about like the increase in blood pressure, as in like a bear with an axe comes into your room, your blood pressure is going to go through the roof, and then you conquer the bear, and then your blood pressure will, the deactivation of the sympathetic.
Yeah, and it's not any different from, again, it doesn't even take bears with axes, right? You walk briskly to Starbucks and back, and by the time you get back and you're sitting down and now resting, right? Or you exercise and you get done exercising. Absolutely. You got to remember, if you think back to 430, we talked about there's this autonomic tone. You're always getting input from your sympathetic and parasympathetic nervous system. However, are those inputs always equal to each other?
No.
No, sometimes the sympathetic's going to be bigger and sometimes the parasympathetic's going to be bigger.
Yeah, that's what I was thinking about by like the actively decreasing activation, like finishing whatever you're doing, or
yeah. And again, we can do the same thing the other way as well. If instead we have a decrease in blood pressure, and we can probably cheat and go through this a little faster. We get a decrease in blood pressure. I'm not even going to bother with the drawings. What's going to happen to the push on our blood vessels?
decrease.
Yeah, there's a decrease in the stretch of the blood vessel. What effect does that have on the firing rate of our baroreceptors?
Decreases firing rate.
Excellent. What effect does that have on the medulla?
Would it increase the activation of the sympathetic?
Excellent. Increases the activation of the sympathetic nervous system, which, as we now know, is really going to have two effects. What are the two effects of increasing activation of the sympathetic nervous system?
Blood vessels to constrict.
Excellent. Our blood vessels constrict, and this increases blood pressure. And what's the other effect?
Increase the strength.
Increases heart rate, cardiac output.
Yep, heart rate and strength of contraction both increase, which increases our cardiac output, which increases blood pressure. Oops. There we go. Excellent. And again, if you don't like the way that I've drawn this on the board, luckily for you, you have this pretty picture from your textbook that shows this baroreceptor factor as well. So again, when blood pressure goes up, we tell the heart to beat less strong and less quickly, decrease in cardiac output. We tell the blood vessels to dilate, and that brings the blood pressure back down. If the blood pressure drops, there is less stimulation to the medulla, and we tell the blood vessels to constrict, bringing pressure up. We tell the heart to beat stronger and beat faster, bring pressure up, and bring the pressure back. Now, lastly, as you mentioned, higher order processing also can affect blood pressure. We talked about this a teeny bit in the last class. So for instance, white coat syndrome, when people have to go in and be tested for their blood pressure, it's often higher than when they test it by themselves at home because they're stressed about being in that medical environment. Or as you mentioned, if you're elated from killing a bear with an axe, or you are meditating or something along those lines, but even pain, right? Or thinking about it. As I said, if we sat here and thought about the lit candle in a dark room and said, om, 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 would our blood pressure drop as a result of that?
Yes. Yeah.
Yeah, if we really pictured a bear with an axe and tried to imagine, you know, how without opposable thumbs he's able to hold on to that axe, and we were able to, you know, think about his big teeth and the foaming of the mouth. And if you really spent, you know, 15 minutes really trying to visualize what a bear with an axe standing in front of you looked like, could your blood pressure go up as a result of that?
Yeah.
Yeah,
Yes.
absolutely. So definitely there's this higher order processing as well, right? For some people, seeing a spider, right? Because again, they don't like spiders, you know, whereas other people have spiders as pets. So is seeing a spider going to affect everybody's blood pressure the same way?
No.
No, exactly. So again, there's a lot of, always hesitant to use the word conscious, but higher order is really the appropriate word. That, you know, that higher order, our emotions, our memories, our personalities, all of those types of things, our experiences, all those types of things have an ability to be able to affect our blood pressure. All righty, excellent.
Go back to the whiteboard, please.
I can. Although I'm not sure it says anything that that other image doesn't better.
I don't. Your drawings are. I understand the concepts more with your drawings.
I appreciate that.
Thank you.
Same here.
Same. I feel like
Okay,
it helps me remember it better than looking at just what the textbook has.
Okay, well, you guys making me feel bad, so hold on, I'll draw this one then too.
We're not trying to get extra credit points by saying that. We're just truly
Because
honest.
I'm not giving them, but
Well, that's good.
there we go. We get the shrink of the blood vessel there as a result of this lower blood pressure. All right, excellent. All right. Any other questions on this before we move forward?
No.
So as I mentioned, I mean, we drew this flow chart, but really, if you think about it, there's really not a tremendous amount of new information here, except kind of how these baroreceptors work. So hopefully, like I said, hopefully the neural pathways, hopefully the neural regulation of this process is something that makes a bit of sense, because it isn't incredibly new information, hopefully. However, what we haven't spent a tremendous amount of talking about is hormones. And so I do want to spend some time talking about how hormones can influence blood pressure. In a way, we've already started talking about this because, as we know, while norepinephrine is a neurotransmitter released by our postganglionic, or heck, let's be specific, most postganglionic sympathetic neurons. As we also talked about, epinephrine and norepinephrine are hormones, long-lasting chemical signals that are released by the adrenal gland into the blood, where they're able to circulate and have an effect on our body. Yes, epinephrine and norepinephrine are slightly different molecules. But for our purposes, and essentially everything related to the cardiovascular system, epinephrine and norepinephrine have the exact same effect on all their targets. So for us in this class, they're pretty much interchangeable. We're not going to worry about any distinctions between those. And when it comes to our blood vessels, we know the effects of that. We know that it is going to constrict essentially non-essential blood vessels. So those are things like to the digestive system, things like the skin, etc. Whereas it is going to dilate blood vessels going to the heart, to the lungs, to the liver, to the skeletal muscle, to again help us deal with that fight or flight. And as we talked about, the global effect is more constriction than dilation. And so as a result of that, it increases blood pressure.
Does it only have an effect on the arteries, or is it veins as well?
Veins as well. Which is why, again, our skin drains of color. We get that pale appearance when we get scared, because all those veins where the blood is slowly chugging its way back in that blood reservoir that is the skin, we constrict them, increasing that venous return, getting the blood back to the heart faster, and our skin gets pale and cold as a result of it. It directly affects the heart as well. To increase heart rate, increase the force of contractions. Again, it's one of the reasons why people like me carry EpiPens everywhere they go. So that if my daughter has an allergic reaction, I believe I've mentioned in this class, my daughter has a severe peanut and tree nut allergy. And so everywhere we go, we keep that EpiPen. So if she goes into anaphylactic shock, I can give her that big dose of epinephrine, and her heart will beat faster, her heart will beat stronger, her blood vessels will constrict, and her blood pressure will go back up, hopefully getting blood to her brain. Again, nothing too new here. We talked about that in 430. Let's talk a little bit about this process. We will go, and I will warn you about this right now, in more depth. We will explain this process when we get to the urinary system. But for now, we just need a basic understanding of what's going on here. Renin is a hormone-like protein. It is not truly a hormone, but it is a hormone-like protein that is produced by the kidney. Why might the kidney play any role in regulating blood pressure?
Water.
Okay, absolutely. There's a tremendous amount of water in it, ions in it. What else do you know about the kidneys?
Cycles waste.
True, it recycles waste. And while you're sitting here calmly in the class, about what percentage of your blood is being directed to your kidneys right now as we speak?
25%.
25.
Yeah, something like 25%. Absolutely. It's not surprising a massive amount of blood goes to your kidneys. So is the kidneys a great place to see what's going on in the blood? Yeah, absolutely. And so not surprisingly, one of the things that the kidney is monitoring is blood pressure. Angiotensin is actually a enzyme that is actually produced by the liver and is actually activated in the lungs. And aldosterone is a hormone that is produced by your adrenal gland.
Professor, I had a question. So when red blood cells old red blood cells, when they're broken down, do they just leave the body through urination, or?
No, the breakdown of red blood cells primarily happens in two locations, the liver and the spleen. So they break down, recycle the components of it so that the body can maintain and reuse the iron so that we can make more red blood cells. So no, the formed elements themselves of the red blood cells, we want to keep. We don't want to lose those.
Okay, thank you.
Yep. So aldosterone is a hormone produced by the adrenal gland. The short-term answer for all of these, with these effect, is in their own way, angiotensin and aldosterone, among many factors, like I said, that we'll go into in more depth in the urinary system, basically tell the kidneys to do two things. They're going to tell the kidneys to reabsorb more water, so we're able to increase in several ways the amount of water in the blood. And why would that affect blood pressure?
Viscosity.
Velocity.
Okay, I like that answer. That's not a bad answer. But remember, viscosity is really one of those factors that affects resistance. It's how sluggish it moves. Is adding more water necessarily going to make it more sluggish?
No, it's gonna
Or
make
is
it dilated.
really it just adds more stuff? More water in the blood means more stuff pushing against the walls.
Yeah.
Right? It's like a water balloon. The more water you put into the water balloon, the more it pushes on the walls and the more that water balloon expands. So when we add more water to the blood, the more volume of water. And then again, we're talking about, I'm always hesitant to use the word volume here. So let's actually change that. Because normally when we think of volume going up, we talk about pressure going down. But that's because I'm changing the size of the room. But if I leave the size of the room the same where you guys are bouncing around, and I add 10 more students in there, you now have more amount of students in there or amount of water in the blood vessels. And if we have more amount of water, more pushing on the walls and more blood pressure. Blood pressure is going to increase. This renin angiotensin aldosterone system also tells the kidneys to reabsorb more sodium. Why would that affect blood pressure?
More sodium is for the contractions for exponentials.
Not a bad guess. That is not a bad guess, although it's not quite that complicated.
What
Yeah.
about osmolarity?
Exactly. Sodium is just stuff. That means we're putting more stuff into the blood. And where stuff goes, what follows?
Water.
So when you put more stuff in the blood, more water follows. That water comes back as well. So notice it both directly and indirectly gets more water in the blood vessel. And when we get more water in the blood vessels, as a result of that, our blood pressure increases. And let's talk about one more you might be fairly familiar with. Antidiuretic hormone. Antidiuretic hormone is produced by your pituitary gland. It's also sometimes called vasopressin because it can cause blood vessels to constrict. But with a name like antidiuretic hormone, what do you think antidiuretic hormone does?
Holds water back.
Yeah, basically it tells the kidneys to hold on to much more water. It concentrates our urine, and it also keeps a large amount of water in your blood. So more water in the blood. And as we talked about, with more water in the blood, more blood pressure. Now, you may not have ever thought about antidiuretic hormone before, but I know you are absolutely aware of it, because luckily this class doesn't start till noon. But if you have a class that starts at 7:15 in the morning, you may need to stop at Dutch Brothers to get that quad shot on the way in. And what's the problem when you drink a whole lot of coffee?
Dehydration.
Yeah, dehydration because you got to pee. Absolutely. What caffeine does is actually suppress the production and release of antidiuretic hormone. So now with less antidiuretic hormone, your kidney releases more water, your bladder fills up faster, and you have to go to the bathroom. And it's not just caffeine, right? Maybe instead of that quad shot on your way to class at 7 o'clock in the morning, maybe it's 7 o'clock Friday night and you just had your 4th Long Island iced tea. What happens when you're at the bar drinking heavily?
Body breaks galore.
Yeah, don't break the seal, right? Once you pee, you're peeing all night long. Clear liquid, because again, you're suppressing that antidiuretic hormones production and release. So you're producing much more very dilute urine. And don't even get me started on those Four Locos, right? With the alcohol and the caffeine in there, right? Bad news. You might as well just sit on the toilet at that point, because then you're also going to be throwing up in there as well. All right, excellent. Questions on any of that?
Nada.
So notice one more thing. All 3 of these hormone regulatory processes that we've talked about all involve bringing blood pressure up. Because as we've talked about, we need that pressure gradient to effectively move blood through our body. So if blood pressure starts to drop, we can have difficulty moving blood to different parts of our body and getting that blood back. And that absolutely positively would be a bad thing, which is why all the mechanisms we have here bring blood pressure up. Because high blood pressure is good, and even higher blood pressure is even better, right? The more blood pressure, the better?
No.
No. So while it is very, very important to maintain that pressure gradient, to maintain the flow of blood, it can be bad to have your blood pressure too high. And so there is a 4th hormone that can actually help us to bring it down. And that 4th hormone is known as atrial natriuretic peptide. As always, there's a lot in the name. Atrial, what do you think that refers to?
Arteries.
Close.
Atrium.
Atrium of the heart, absolutely. I mentioned it. I don't remember how much I emphasized it, but I'll make sure to emphasize it here. What did we say the blood pressure of the blood should be when it
Around 120.
reaches the atria of the heart?
0.
When it reaches the atria of the heart, we said it should be at 0 millimeters of mercury. Excellent. However, if our blood pressure is too high, when it reaches back to the heart, to the atria, it's not at 0 millimeters of mercury. So if the pressure is greater than 0 millimeters of mercury, that causes our atria to stretch. We have these baroreceptors, these stretch receptors in our atrium of the heart. And when the atria of the heart stretches, it causes it to release atrial natriuretic peptide. And atrial natriuretic peptide tells the kidneys Hey, kidneys, I need you to get rid of water. I need you to get rid of sodium. And why would we want to get rid of sodium?
Less stuff left in the water.
Right, because where sodium goes, water follows. So notice by getting the kidneys to get rid of water, to get rid of sodium, which gets rid of water, this would allow us to lower our blood volume. And if we lower our blood volume, that allows us to lower our blood pressure. So yes, it is vitally important to maintain a nice, healthy, high blood pressure. But like everything in life, too much can be bad for you. And so not surprisingly, we have mechanisms like this Atrial Naturatic Peptide that can help us hormonally to release more water to bring our blood pressure back down.
Does it release or does it lower the blood volume, or is it just less amount of stuff in the blood?
If you get rid of water and you get rid of salt and then that causes you to get rid of water. If you're getting rid of water from your blood, yeah, you've got less blood volume.
Okay, I just know on the one above you were saying you didn't want to put like more volume of water.
So yes, you're right. Lowers blood amount. You're right. You're right. So yes, and again, if you think about it, if I have a liter of water, that is a volume of water, right? If I pour 200 milliliters out, I have 800 milliliters of water. That is a volume of water. So yes, you're right. I know, I appreciate that it's confusing. So you're right. I'll change. Thank you for reminding me of that. So we change it there. Yes. We have less amount of water in the blood. So we have less amount of blood and therefore less blood pressure. Thank you.
Are those receptors only in the right atrium or both?
It is in both, although typically it's the right one where you see those kind of pressure changes more. So yeah, so I would say it's mostly the right.
Sorry, Professor. If you have higher blood pressure, and we were talking about how with the blood, when it comes back to the right atrium, it just kind of leaks in, and then starts filling up the right ventricle. With having higher blood pressure, would it fill that more, kind of thing? Would it just push more blood into the right ventricle?
Probably yes, because you would have an increased volume of blood likely coming back, or at least blood with a higher pressure, which would likely open your atrioventricular valves sooner, causing more blood to enter into your ventricle. Yes. All right. Any questions on these 4 hormonal regulatory processes for the blood pressure? I know we did a little bit of hand waving on this one here, but like I said, we're going to go into more depth on that one in the urinary system. So for now, you just have to have a basic understanding of how it works. We will talk more specifics when we get to the urinary system.
Should we expect like essay questions to describe these pathways, this process?
Is describe the hormonal, the hormones that are responsible for regulating blood pressure and how they work? Is that a kind of an essay question that would be a great essay question? Yeah, absolutely. So you should know these hormones and how, and in general, how they work. Absolutely. The same way we could do the same thing with the neural. Describe the neural mechanisms for regulating blood pressure. Yeah, absolutely. Any of these things that have, steps or have different components to it are all things that make good essay questions.
Or maybe even like compare and contrast.
Yeah, I'm not sure you would necessarily compare and contrast hormones versus neural regulation in that way. I'm not sure that in this case makes a good essay question, but definitely know your hormonal and your neural regulatory processes. Absolutely. And again, here's that pretty flow chart from your textbook that shows how it all works together. All right, questions on that? All right, this is a good stopping point. Let's go ahead and take our first break here.
I have a quick question and
Yes.
clarification regarding vasopressin. So you talked about kidneys holding on to water. So are you referring to the bladder filling up with water, more water?
But see, remember, if your bladder is filling up with water, it is because your kidneys have already released it from the body. Once that water is released by the kidney, it is essentially out of your system at that point. There's no mechanism in your urethra, your readers, or your bladder to reabsorb that water. Really, think of it this way. Every single person in this class right now, as we speak, you are urinating, right? Because if you think of the true definition of urination, it is the production of urine. That production of urine is occurring from the kidneys. The kidneys are filtering water and materials out of your blood into a waste fluid that we call urine. However, while all of you are making urine as we speak right now, hopefully it's not dribbling out of your body, right, continuously. And that's because we have the ureters, the urethra, and the bladder, which basically are just storage till we can get to a socially appropriate location and then void those things from our body. So yes, by the time it's in the bladder, it's no longer considered a part of our body. So it can't affect volume, it can't affect blood pressure or anything along those lines, because at that point it's waste and has no mechanism of getting back into our body. Great question. Does that make sense? Excellent. All right. Any other questions? All right. Excellent. Then I will bring us here. Like I said, we'll take our first break, 15-minute break. Looks like that means what time is it now? 1:05. So we will come back at 1:20, and at 1:20 we will pick up the lecture from here. All right. See you guys in 15 minutes. All righty. Real quickly, before we get started, for those of you who are still on the trial, I heard back from, for the Master NANP, I heard back from our tech during the, or not our tech, but our, the book person, representative. And two things, good pieces of news. The first is that bundles have been delivered today to the bookstore, so they should be available within the next couple of days, but also they're going to go ahead and extend the free access to the Master NANP through the weekend. So you should hopefully be able to access during this weekend. And if you haven't already been contacted by the bookstore, then please reach out to the bookstore because they should have all the materials now that are being back ordered. All right, so any questions on any of that? All right, excellent. Then let's dive in from here. Again, we've talked about the goal of maintaining homeostasis and the importance of maintaining things like blood pressure and blood volume and all those types of things. And as we talked about, again, we've talked about in broad strokes, hyper and hypotension. And we're not going to worry about the numbers of that because, again, that can easily be debated. But I do want to talk a little bit about these conditions, starting first with hypertension. With hypertension, hypertension can be transient or it can be persistent. And what does that really mean?
Come and go or constant.
Mm-hmm. Excellent. It can be acute or short term, or it can come and go, or it can be something that is constant. Probably more important for you guys as medical specialists, hypertension can be primary or essential, or hypertension can be secondary. Now, by primary or essential hypertension, this is stuff brought on by risk factors like your weight, your age, race, heredity, stress, smoking, right? Obviously, some of these things aren't things that you can change. You can't change your early age, at least not for the better. It always gets worse, right? But you can affect where you work. You can affect the stress in your life. You can affect smoking and obesity and things along those lines. Whereas secondary hypertension is really hypertension that is due to some other type of disorder that you are experiencing, whether it is a hardening of the arteries or an endocrine or hormonal imbalance or something along those lines. Why is it necessarily useful for identifying whether hypertension is primary or secondary?
To know if you should treat it directly or treat the main cause of it.
Absolutely, exactly. It has everything to do with treatment, right? If you're dealing with secondary hypertension, where you've got some type of hormone imbalance in your body, right? Going and living in a yurt, right? Stopping smoking, changing your diet, becoming vegan, all of those things, none of those things are going to help and influence and change that hypertension. That hypertension is being brought on by some other type of medical condition or disorder of the body. And when that is resolved, then the hypertension will resolve as well as well. So you're absolutely right. The primary reason this is important is for how you are going to address it, how you are going to treat that condition to help that person get better. And even hypotension is something that can vary in its causes. We already talked about the simplest example of this, what we call the orthostatic hypertension, where if you rapidly stand up from a sitting or a reclining position, you can get a partial drop in blood pressure just because the heart has been having to work less efficiently. So when you're laying down, it doesn't have to work as hard to get the blood to pump to your brain. And so when you suddenly sit up, it takes a moment for the heart to compensate for that increased force that it has to produce to modify the blood pressure to keep a constant blood flow to your brain. And so you may get a very temporary dizziness as a result of that. However, chronic hypotension can be caused by numerous conditions, most commonly poor nutrition. So malnourished individuals typically tend to have hypotension. However, there are some other hormonal disorders. Having hypothyroidism is one example, or another great one, well, not great because it's not great when you have it, Addison's disease. Addison's disease is a disease of the adrenal glands that can cause, among other things, chronic hypotension. So if that hypotension is persistent, then that is something that needs to be examined. But again, it doesn't have to be persistent. There can be all sorts of acute hypotension. This can be something that is monitored very, very closely when someone is post-operative, right? This can be caused by some type of circulatory shock, damage, or injury to the heart, or it could be caused by some type of internal bleeding. If someone is recovering from surgery and suddenly there is a rapid and distinct drop in blood pressure, right? One of the causes, as we've talked about, that can be a drop in the blood volume. Now, obviously, if blood is spurting out of the side of their neck, that is obvious and you understand the cause of that. But if it is an internal bleeding, you may not be aware of it till it's too late. So like I said, typically post-surgery, it's something that blood pressure is monitored, something that's monitored very, very closely to watch for any of those types of nicks or unclosed wounds internally that need to be resolved.
Professor, the Addison's disease, you said that had to do with the adrenal glands. It just mean that it doesn't release the epinephrine into the body, kind of thing. And
Great question. So that's an excellent question. And as we will learn in the next section when we get to the endocrine system, the adrenal gland is most commonly known for the hormone named after it, adrenaline. But the adrenal gland actually produces dozens of hormones, 4 main classes of hormones with different types of functionality to them, affecting things like available glucose levels in the blood, affecting things like ion concentrations and all sorts of other things as well. So Addison's is primarily involves the corticotropics of the adrenal gland, which again, I know doesn't make any sense now, but we will talk about that more when we get to the adrenal gland in the next section. But no, it's not adrenaline. That's a great question. It's one of the it's a class of hormones that is produced by the adrenal gland. that are related to adrenaline, but not actually adrenaline? Great question. All right. So, as we mentioned, the function of our cardiovascular system is to be able to deliver oxygen and nutrients to the tissues of our body to meet their demands. And if it's not able to do that, then we call that cardiovascular shock. As we talked about, there are many things that can be causing that. One could be an inadequate perfusion, so a blood vessel could be blocked, stopping blood from going to an area. It could be that someone's holding a plastic bag over your head, so you're getting less oxygen into your lungs and therefore into your blood. It can be that you're too vigorously active, leading to that anaerobic respiration, that increase in lactic acid, which, as we talked about, can be damaging to our heart. And as that heart or other tissues are receiving decreased oxygen, it produces more and more of that lactic acid. And that lactic acid, as we talked about, can be damaging, and in extreme cases can cause cell damage or cell death. There are different types of cardiovascular shock. One of the most obvious ones, when you're fighting that bear with an axe and he takes a big, huge chunk out of your shoulder and large amounts of blood are pouring out of your body, as we've already talked about, decrease in the amount of blood. And again, to avoid confusion, that's what we're talking about, the amount of blood. The less blood you have in your body, the less blood pressure you have, the harder it is to get it spread throughout the body. However, as we also talked about, internal bleeding can cause hypovolumetric shock and extreme diarrhea or nauseousness. If there's a large amount of vomiting and or diarrhea, you could be losing excess fluids from your body as well, and that extreme dehydration can cause someone to go into hypovolumetric shock, volumetric shock. Cardiogenic shock is kind of the one we already talked about. This is where there is damage to the heart. As we talked about, it's typically asymmetrical, starting on one side of the heart or the other. But it doesn't even have to be damage, as we also talked about with the example of anaphylactic shock. If there is a rapid, inappropriate vasodilation, where you have a rapid drop in blood pressure, like an anaphylactic shock, or also in a vasovagal reflex. In a vasovagal reflex, you can get an inappropriate dilation of blood vessels, causing someone to pass out at the sight of blood or when they're stressed or something like that. Those great fainting goats are a great example of that. And then lastly, obviously, it could be some type of obstructive shock where a blood vessel is blocked, stopping blood from, for instance, getting to the lungs to get the oxygen that is necessary, blocking blood vessels going to the liver to get the nutrients necessary, or just blocking the blood to a specific region of the body that doesn't have those collateral anastomoses that we talked about. That can cause damage as well. All right, any questions on any of that? I can, although again, all of these should be on your handouts that you have at least access to look at. Is this the one you wanted? Often obstructive shock is due to blood clotting, yes. Blood clots form, damage to the blood vessels causes an accumulation of blood clots or increased cholesterol or things along those lines. All of those are things that can cause blood clotting, yes. And so typically blood clots cause that obstructive. I'm sorry, was somebody else asking a question?
No, I just said thank you.
Oh, yep, cool. All right, excellent.
And I actually had a random question. I mean, it's kind of thinking that it might be woven into this, but like when somebody has like hyperventilation, right, and their heart is like they're breathing really fast, their heart's going really quick, and that's why, is that why you give a bag, you have them breathe through a bag so there's carbon dioxide, and does that bring down the heart beats as well?
Indirectly. What typically when someone is hyperventilating like that, as you pointed out, what you're getting is a dramatic drop in CO2. And again, we'll actually talk about this in the respiratory system, but this is a good part to say that there's this magical thing that happens in your body where when you take carbon dioxide and you add it to water, something special happens. Anybody know what happens when you add carbon dioxide to water? Yeah, you get an acid. And so that carbon dioxide in our bodies plays, not only is it an important waste that needs to be expelled, but the goal isn't to get rid of as much of it as possible, because our carbon dioxide also plays a very important role in helping us to maintain the pH of our blood. So typically what happens when someone's hyperventilating is they're dramatically dropping the CO2 levels in our blood. And if the CO2 levels drop too much, that can actually cause someone to pass out, right? Lose consciousness as a result of that. The advantage of the losing consciousness is typically what is causing the hyperventilation is some type of higher order processing, stress, or some other type of things along those lines. And so if you want to avoid getting to that point of passing out, by having them breathe into a bag, they reclaim more of their CO2 that they're breathing. The CO2 goes up in their internal volume, maintains that CO2 and keeps the levels up until normal breathing rates can be reestablished. If you pass out, normal, right, all that top order pressures go away and your normal respiration will begin again as well. But most of us don't like to get to the point where we pass out, especially if that means falling down to the ground, to get to that point. So breathing in a bag is a way to circumvent that passing out and to recapture that CO2, maintaining appropriate blood pH. All right.
Okay. Yeah. And another just random question. When somebody is so for me, I went to the hospital one time, was hyperventilating, and my hands started constricting. My muscles, kind of were like closed up and turned in. Was that from excessive oxygen or just lack of CO2?
It would probably have more to do with the CO2 and the effects of that on the pH and the effects of that way. Again, when you're hyperventilating, you're not dramatically increasing the amount of oxygen in your blood. What you are doing is dramatically decreasing the amount of CO2.
Okay.
Yeah. And yes, absolutely, Samuel, you are correct. It is carbonic acid. But like I said, we'll wait till we get to the respiratory system to talk about that specifically, carbonic acid and how it disassociates into hydrogen and bicarbonate and all the fun things that go along with that. We'll save that for the respiratory system. All righty. And urinary, I guess, for that matter. Okay, so last major concept we need to talk about is, we know the capillaries are where the exchange of material takes place, but we haven't really talked about why. Why is it that in the capillaries, this exchange takes place? Again, one of the issues that we mentioned is that the vast majority of materials that are passing into or out of the capillary, either through that the intercellular cleft or through like a fenestration or something like that, is via diffusion. And so as we know, diffusion is the movement of water and solutes being driven by pressure or concentration gradients. And so it is these pressure gradients inside the capillaries that are going to be what caused this effect. Now let's take a look and do this on the whiteboard first. We'll do this on the whiteboard first. And then after we do this on the whiteboard, then we can come back and look at all the pretty pictures and everything associated with this in the all right, oops, wrong place. let's start by drawing a blood vessel. Now that I've done that, let's cheat and move this all over a little bit more. All right, for our capillary exchange, there are two main factors that are influencing and modifying the capillary exchange, or basically two main pressures. The first of these pressures is hydrostatic pressure. Can someone remind me again what hydrostatic pressure is?
It's like liquid, like pressure, liquid pressure.
Yeah, liquid pressure doing what? It's the pressure of liquid, in this case, the liquid's going to be the blood, doing what?
Going down its gradient.
No, not necessarily pushing down its grade. I heard someone else started to say it. What were you saying?
Pushing against its boundaries.
Yeah. Excellent. And with that definition, what does that sound an awful lot like? When we, up to this point, when we've been talking about blood pushing against its boundaries, what have we been calling that?
Blood pressure.
Blood pressure.
Blood pressure, exactly. This is basically our blood pressure. The force of our blood pushing against its boundaries. All right. If you think about it, we've already talked about what this is. We know here's our capillary. And over here is our arterial. And over here is our venule. And we know that not only is blood pressure going to be important for the capillary exchange, but as we know, blood pressure plays a role in the movement of blood from one part of the cardiovascular system to the other. Remember, way back at the heart, where it first left the heart, it left at 120 millimeters of mercury. And what is it when it reaches back to the heart into the right atrium?
0.
0. So it's going to go from 100 to 0. Does anybody remember what at the arterial end we said the hydrostatic pressure?
Was it 45, 50?
Close. So the hydrostatic pressure of the blood, we said was 35 millimeters of mercury. All right, by the time it reached the arterial end, it was 35 millimeters of mercury. And let's go ahead and make this blue. And anybody remember what it was at the venous end?
17.
Yeah. So the hydrostatic pressure, the blood pressure of the blood is 17 millimeters of mercury. Excellent. That makes sense. Questions on that? Excellent. But hydrostatic isn't the only type of pressure we have inside of the blood, because after all, the blood is both plasma and stuff. And what do we call that pressure that the stuff inside of the blood has?
Osmotic.
Yeah, exactly. So our second pressure is an osmotic pressure. That osmotic pressure is basically the force of the stuff in the blood to draw water to it. Oops, that should be two. Turns out the amount of stuff osmotic pressure of the blood, or what is known as the blood colloid osmotic pressure. Blood is a colloid. What is a colloid again?
Is it a water with particles?
Yes, suspended in it, right? Because like you said, you wouldn't say the red blood cell is dissolved in the blood, right? It's suspended in it. So our blood colloid osmotic pressure, or the osmotic pressure in the capillary, however we want to describe it, is basically 26 millimeters of mercury at the arterial end. Now, after exchange takes place, do you think that's going to be the same, or do you think it's going to be different at the venous end?
Different.
Why? Why do you think that?
Because there's less
Because
stuff.
there's the exchange of.
True, there is exchange. Water's going to move, substances are going to move, but remember, it's all via diffusion. So if water moves, stuff goes with it. If stuff moves, water follows. So is there any way we can actually change the amount of stuff that's going to be in the blood without using ATP? Or at least the percentage of stuff? It may be different stuff, but the numbers, as it turns out, are going to be the same. So this osmotic pressure is actually the same at both ends. So it turns out it doesn't really change. Because this is a passive process, it doesn't change. Now, there's one other concept we have to think about here. For this hydrostatic pressure, is this pressure trying to move things out of the capillary or into the capillary? Well, hydrostatic pressure is water pushing against its boundaries. And if that boundary happens to be permeable, like a capillary is, then this is going to be an outward force. In relation to the capillary. But what about the osmotic pressure? Osmotic pressure is the stuff in the blood trying to bring water to it. So if it's trying to bring water to it, would that be an inward or an outward force?
Inward.
Excellent. This would be an inward force. All right. With me so far?
Yep.
Excellent. So again, this is, whoops, hold on. No, shoot.
Have you had too much water in
Let's figure out how it works
your system?
normally first, then we'll mess it up.
Sorry, okay.
Yeah. I like what you're thinking. I like where you're going, but let's understand how it works first normally. And then again, we can show that understanding by messing it up and seeing how messing it up would affect it. Because we only have half the story here. Yes, I have my capillary, and that capillary is filled with blood, which, as we just finished talking about, is water and stuff. But isn't there water and stuff out here surrounding the blood vessel?
Yes.
And what do we call that water and stuff that is surrounding the blood vessel?
Interstitial fluid.
Interstitial fluid. Excellent. Whoops, no, hold on. I want you to stay there. Excellent. And if interstitial fluid is water and stuff, then do you think that that water inside the stuff can be pushing against the capillary? Can we have a hydrostatic pressure of the interstitial fluid?
Yeah.
Absolutely. What we would call the hydrostatic pressure of the interstitial fluid. Absolutely. And since we have stuff in our interstitial fluid, can that stuff draw water to it?
Yes.
Yep.
So we have an osmotic pressure of the interstitial fluid. And let's think of in terms of the capillary. In terms of the capillary, oops, no, hold on. I want that to be, pick a different color, purple. This hydrostatic pressure, this is the force of the water pushing against its boundaries. So as such, would this, do you think, be an outward or an inward force in relation to the capillary?
Inward.
Inward.
Excellent. This is indeed an inward force. Conversely, the osmotic pressure is going to be stuff drawing water towards it. And would that be an inward or an outward force?
Outward.
Excellent, because it's drawing water to it. So now there's just one thing we need. And that thing we need are the numbers. Now, do you think the hydrostatic pressure and the osmotic pressure of all tissues in our body are all going to be the same?
No.
No, of course not. So there's going to be some variation on this. Hydrostatic pressure can actually sometimes be positive and sometimes can be negative. But in general, as a good general rule, it's kind of zero. Because if you think about it, hydrostatic pressure of the interstitial fluid is the force of the interstitial fluid pushing against the boundary of the capillary. Now, the blood is trapped in the capillary, and that's the only place the blood can go. Is sitting up right next against the blood vessel the only place the interstitial fluid can go?
No.
No, so there's no reason for it to be sitting there beating its head against the capillary. There are some parts of the body where it could be positive or negative. It can change. But in general, when we're trying to calculate what's going on here, it's usually just 0. And the same thing, if the interstitial fluid isn't hanging around a lot near the capillary, it's not going to have a strong effect. And it can be anywhere from, I don't know, 0.5 to as much as 5 millimeters of mercury, somewhere in that range. However, in general, for a good general number, we would use 1 millimeter of mercury. So those are our 4 pressures. Does every single one of us in this class, are all of these numbers identical for all of us?
No.
No. So are these absolute numbers vital that we memorize them and know them?
No.
No.
It's useful. We might want to know these numbers, but it is even more important for us to understand how they relate to each other.
Yeah.
Yes, absolutely. And so now that we have these numbers, what we can do is we can come over here and figure out how we can actually calculate how the water and materials move in a capillary. So for this, we need some equations. The first of these important equations that we need is what is known as the net hydrostatic pressure. And how would you guess we get the net hydrostatic pressure?
We just add the different hydrostatic pressures.
True. Okay, but let's cheat. Hold on, I'm gonna have to go back for a second. So let's erase this.
You subtract the low from the
Notice,
high.
notice when we look at the 2 hydrostatic pressures, one's an outward force, one's an inward force. Since they're going in opposite directions, do we necessarily want to add them together?
No, you want to find the difference between them.
We want to find the difference between them, exactly. So what we actually want to do to calculate the net hydrostatic, actually, let's leave this big. I like it bigger. Is because, again, we always want to think of these things in terms of the capillary. So we are going to take the hydrostatic pressure of the capillary, or the blood in the capillary, and from that we are going to subtract the hydrostatic pressure of the interstitial fluid. And that would give us our net hydrostatic pressure. And just out of curiosity, let's go ahead and do that. What was the hydrostatic pressure in the capillary? Oh, again, we need to do this at the arterial end, because it's different at the arterial end versus the venous end. So at the
35.
arterial end, what was the net hydrostatic pressure?
35.
35 millimeters.
Equals 35 millimeters of mercury minus what was the hydrostatic pressure of the interstitial fluid?
0.
Which is going to equal what?
35 millimeters
35.
mercury.
Excellent. Remember, always show your work when you're doing this type of an essay question, which you're very, 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 very likely to see on the exam. Excellent. Perfect. So now we know our net hydrostatic pressure. Although, let's think about this. Is this an outward or an inward force?
Outward.
Excellent. Now, we've calculated the net hydrostatic pressure. What do you think we have to calculate next?
Hydrostatic pressure on the osmotic pressure.
There you go. We need to calculate the net osmotic pressure. And guess how we would go about doing something like that?
Osmotic pressure of the capillary minus the osmotic pressure of
The interstitial fluid. Perfect. So again, at the arterial end, let's do that. So our net osmotic pressure would be equal to what?
26.
Minus,
1.
1.
which equals
25.
25.
5 millimeters.
3. Excellent. And is this one an inward or an outward force?
Inward.
Excellent. Questions on that? Now we need to combine the two. Oh, wait, hold on. I'm sorry. I didn't see that there was a question there before. Hydrostatic pressure of the interstitial capillary, and because it's pushing against the blood vessel. So if the blood vessel was leaky, it would push the water into the capillary. So that's why it's considered a force, because it's pushing against its boundary. And if it were to pass through that boundary, it would go into the capillary. So that is why it's the, did that make sense, Samuel? Okay, perfect. Sorry. All right.
Would we need to calculate the hydrostatic pressure on the venial side as well?
Could we?
Yeah. I
Yeah,
mean,
would
would
be something
do
that
we
would
need
even
to?
be worthwhile to do after we're done with this one.
Yeah.
Yeah, let's do that. But let's finish this one first, because we're not quite done. We have a net hydrostatic pressure, net osmotic pressure, but we know these two pressures are working together, or really, if you look at them, one's an outward, one's an inward, they're working against each other. So what we need to calculate is a net filtration pressure. And guess how we calculate the net filtration pressure?
Outward minus inward.
There you go. Or in this case, our net hydrostatic pressure minus our net osmotic pressure. So you are correct. If we were to come here to the arterial end and calculate this, our net filtration pressure is equal to what?
35 minus 35.
35 millimeters mercury minus how much?
25 millimeters mercury.
Which equals?
10 millimeters mercury.
And being a positive number, is this an inward or an outward force?
Outward.
So there you go. So notice if we go back to our pretty picture, here in our pretty picture at the, what color haven't I used yet? I don't know if the yellow will show up well, so let's use just, we'll see if the yellow works. Net filtration pressure, make this nice and big. Bold. Our net filtration pressure is a positive 10 millimeters of mercury, which means that water and the stuff dissolved in water are exiting the capillary. And when water and stuff exit the capillary, we call that filtration. Excellent. Questions on that? All right. We have had a request to then do the venous end. Oops. Don't want that. Don't want that. Do want that.
With the pressure going from the arterial end to the venous end, like changing from 35 down to 17, would it kind of be like across the board? I mean, I know that we're just doing one side, but would it kind of be like a sliding scale, and how
Yes,
much?
absolutely. But let's look at the two extremes. Let's look at the arterial end and let's look at the venous end, and then we can kind of figure out what's happening along the way. So let's do this. Walk me through all of it. Because like I said, if this was an essay question, you would need to do the work for me. So what's the first thing? Show your work for full credit. What's the first thing we have to do?
Hydrostatic pressure of the capillaries, 17 millimeters mercury.
Okay, excellent. So we need to calculate our net hydrostatic pressure. So to do that, we would take the hydrostatic pressure of the capillary at the venous end, which is what?
17 millimeters.
Excellent. And from that, what do we do?
Subtract the hydrostatic pressure of the interstitial fluid,
Which is?
0 millimeters
So what is that
mercury.
equal?
17 millimeters mercury outward.
Excellent. We would then need to calculate our net osmotic pressure. What would that be?
Same as the arterial end, 26
Right. Of course,
millimeter
you
mercury.
wouldn't write that on an exam. You'd
No,
have
no,
to write it out. But yes, you absolutely have the right idea. Notice those numbers don't change. So it is still a 25 millimeter change, and it is an inward force. So then what do we have to do next?
Take net hydrostatic pressure, subtract net osmotic pressure.
Which is how you calculate the net filtration pressure. Absolutely. So your net filtration pressure. And so that would be what?
17 millimeters mercury minus 25 millimeters mercury, -8 inward.
Yeah, notice now with a negative number, we have an inward force. Everybody understand how we did that calculation?
Yes.
Excellent. So notice two things now. Now at the venous end, we have a net filtration pressure of -8 millimeters of mercury. So which way it is water and stuff moving now?
Inward.
Water and stuff is now moving inward. And when water and stuff enter the capillary, we call that reabsorption. Nope, I guess I should capitalize that like I did for filtration. Reabsorption. So you are correct. Starting at the arterial end, we're going to have the most amount of filtration, and then less and less and less and less and less. And then at some point, are you going to get like an equal movement of stuff in and out?
Yeah.
Some kind of equilibrium, and then slowly stuff will start to move back in. So yes, there is a gradient as we move through here because there is going to be a gradient in pressures as we move from one end to the other. Absolutely. But notice one last thing on this. Do we have
No.
the same movement inward that we had outward at the beginning?
No.
No. So what does that tell you about your capillaries?
Net movement out of capillaries.
Right. So during the 24-hour period of time, as all your blood is running through all of your body, every time your blood goes to the capillary, a little bit of extra water and stuff goes out and doesn't go back in. So by the end of the day, why aren't your blood vessels completely empty of blood? Why isn't every part of your body swollen up like a big, huge balloon from all this water and stuff that's leaking out of the capillaries?
Because we drink water?
True, some of it is we're able to add water back in. That would help us to keep the water in the blood vessels, but that would, I'd still be blowing up like a balloon, swelling and getting edema everywhere in my body.
Evaporation.
Yeah, but this is happening
sweating?
deep inside my body.
Kidneys?
The lymphatic system moving
There we
stuff
go.
through.
Amanda's got it. Absolutely. The lymphatic system. Your lymphatic capillaries are responsible for taking extra fluid in our interstitial fluid and dumping it into the cardiovascular system. And does it do it just blindly, grabs it and dumps it in there and hopes for the best?
No.
No, it inspects it. Is there anything abnormal, dead cells, debris, pathogens, cancerous cells, anything bad in here that I can get rid of before I dump it back in? Yeah. Our lymphatic system is vitally important for helping us to reestablish this blood volume, to take that extra fluid and dump it back.
So would lymphedema be just like that not working properly?
Yeah, that could be one cause. Or the other thing I was thinking of is a more extreme case. If you've ever known somebody who's had cancer or precancerous cells in their lymph nodes, they may have had some of their axillary lymph nodes, for instance, removed. And when that typically happens, swelling in that arm is usually a big problem as a result of that, because you've disrupted the lymph flow in those lymphatic vessels, getting that blood back, and suddenly you get more swelling and stiffening of the joints and things like that while those lymphatic vessels regrow.
Did you have like too much salt or sodium or anything like that in interstitial fluid and have more?
Sure, absolutely. So that's a great question. And that's the other point that I wanted to make about this. Absolutely. Anything that can affect one of these four numbers can modify, oh, stupid cap, stupid blocks. Absolutely. So if you have an increased number of solutes, either in your blood or in your interstitial fluid, would that affect the osmotic pressures?
Yeah.
Yeah. Or even something like I slam my hand in a car door and the cells there release that histamine chemical. What does histamine do?
Does dilate
Flames?
blood vessels?
Yeah, it dilates blood vessels, bringing more blood to the capillary. More blood to the capillary means a higher hydrostatic pressure, meaning a bigger outward force. And on top of that, it also makes the capillaries more leaky, making it easier for the fluid to come out, right? So that's why you get that edema. You got more blood coming to the area and the blood vessels are more leaky, so it sneaks out, right? You get swelling. All that blood is bringing heat and red blood cells, so it gets warm, it gets red. It pushes on the nerves, it hurts. Right? And those are the four cardinal symptoms of inflammation, right? Heat, redness, swelling, and pain. All from that histamine chemical that's causing that. So yeah, any of those kind of factors could influence and change these. So do you need to understand how changing these numbers would affect the function of a capillary?
Yeah.
Yes. And more importantly, could I give you any four random numbers for your hydrostatic pressures and your osmotic pressures, and you be able to calculate a net filtration pressure for me?
Yes.
Yep.
Absolutely. And is that exactly the kind of thing you'd be likely to see on an exam?
Sure.
Most definitely.
Yeah. And then explain whether it's an inward and outward force, whether it's involved in resorption or filtration, and again, so on and so forth. Absolutely. So again, I've done this with all the pretty words and pretty pictures. Your book's got a great job of doing this. Again, notice your book is so elegant in some of its terms. It talks about the hydrostatic and osmotic pressures of the blood, and it talks to them about the push and the suck of the capillary. So the outward and the inward forces of those in the capillaries. Again, outward forces cause filtration. And remember, there's basically two outward forces, the capillary hydrostatic pressure, and I gave you those values. The interstitial colloid osmotic pressure, which again, as I said, is 1, although it can vary. The two inward forces cause reabsorption. They're the blood colloid osmotic pressure, which we mentioned is 26, and the interstitial fluid hydrostatic pressure, which, like I said, can vary dramatically from tissue to tissue. But in a typical capillary, systemic capillary, it's going to be 0. All right. And then it's all about the calculations. Calculate your net hydrostatic pressure. Make sure you explain what that is. Calculate your net osmotic pressure. Explain what that is. Put them together into a filtration pressure. And again, if it's positive, it's an outward force. And if it's negative, like at the venous end, it is an inward force. So again, this is just the stuff we did. Understand these relationships, understand these calculations, and always show your work. Don't just write down an answer. Show me how you got that answer. Explain your equations. Don't just randomly add and subtract numbers. Explain to me what you're doing. Because that's the key. If you explain to me how you're doing the question, and you end up with +5 instead of +10, and I see that all you did was add something wrong, but all of your information is there, you're going to get most of the points. However, if you just put a 5 down with no explanation, then I have nothing to go by. I just see that your answer is wrong. And even if your answer is right, if you don't show me the equations, if you don't show me your work, how do I know you didn't just guess or put them together in the wrong way? So make sure you show your work for full credit on these things. I literally will give you any 4 random numbers and some random alien capillary we find somewhere on some other planet, and you'll have to tell me how it works. All right, and as I said, at the arterial end, it is mostly an outward force. At the venous end, it is an inward force. And again, notice that inward force is not as great as the outward, which is why we need our lymphatic system. Of course, we kind of already talked about this, but I'll remind you again, edema is an abnormal increase in interstitial fluid caused by injury. Could be caused by excessive filtration, inadequate reabsorption, ionic imbalances. And as we talked about, edema leads to swelling, inflammation, tightening of the joints. Often it's not noticeable till it gets pretty severe, except like we talked about inside the cranial cavity, where edema is a very, very severe condition. All righty, questions on any of that?
Yes, question. Can you go back to your diagram? Had a question regarding the interstitial fluid, your inward and outward. So understanding hydrostatic pressure is inward into the capillary beds, correct? And the
Yes.
osmotic pressure is outward, so meaning, but this is interstitial fluid, it's already outside of the capillary.
But remember, I love where you're going with this, but what you have to remember about this is we are talking about capillary exchange, the exchange in the capillaries. So when we're talking about outward and inward forces, we're talking about them in relation to the capillary. not in relation to the interstitial fluid, but in relation to the capillary. As you mentioned, this is an inward force because it is moving towards the capillary, into the capillary. This is an outward force because it is moving outward, away from the capillary, out of the capillary. So when we're talking about this being an outward force and this being an inward force, we are talking about them in relation to the capillary, not in
Great,
relation
thank
to the
you.
interstitial fluid, but in relation to the capillary. Yeah, because it's the capillary exchange. Notice also it helps you with the equations. Notice when we're doing the equations, we always put the capillary stuff first, right? We put the hydrostatic pressure first. We put the capillary. We put the osmotic pressure of the capillary first. We talk about then we do the hydrostatic pressure first for the net filtration pressure, because it's all in relation to the capillary. It's just the capillary exchange that we care about. Great question. Any others?
I have a question, just to clarify, because I was writing, I think when you went over this, you will give us our like random numbers. These ones are a good reference, but we don't have to completely memorize them for the exam.
So, okay, here's what I would say. Because we also talked about it in terms of the flow of blood, the movement of blood through the blood vessels, knowing what the blood pressure is at the arterial and the venous end, is that something that is important?
Yes.
Yes.
So those are numbers that you probably need to know. These other three numbers, especially the interstitial fluid ones, because they can vary so much, they're not as important. Even the osmotic pressure at this point isn't as significant. So I would say those numbers aren't as important as well as it is if I gave you some random numbers, you need to be able to do those calculations. So if I were to, like I said, if I were to give you some just completely out of the blue random numbers, and again, they could be completely random. This could be 117, right? This could be 452, right? This one could be, 2,783, right? This one could be 1, right? I can give you any 4 numbers and you should be able to plug them in. I won't pick numbers quite this random, but you get my idea. Understanding this relationship is much more important than memorizing these numbers for the capillary exchange. However, since these 2 numbers up here, we talked about in relation to something else, that it might be useful to remember those numbers.
Perfect. Thank you.
Yeah. All right. Awesome questions. Any others? All right, spectacular. That is everything that I wanted to talk about for our blood vessels. So what we are going to do is take one more break. When we come back from break, we are going to start our introduction. Close that. Close that. To blood vessels, to our blood. Start our introduction to the blood. How far do I want to get into this? All right, we'll see how far we get into this. Probably not going to use all of our class time today, but I want to at least start our introduction to blood. So we will start with that. Let's go ahead and bring that up. And then that'll be all we'll do for today. Again, the problem from a lecture standpoint for this is that this section, the cardiovascular section, we usually have a lot of physiology we're doing in the lab. And so normally the lecture time isn't as long because we're doing things like the heart dissection, we're doing things like the ECG and stuff like that. And so you're still doing those activities, you're just doing them on your own. So when we get to the end of this section, we don't have quite as much to talk about. So we'll finish a little bit early, but I want to stay ahead. So we will start. I don't want to save all the blood stuff for Thursday. So let's go ahead and take our last break. It is 2:23, so that means come back at 2:38. We will restart. And at that point, I will start the recording. All right, so any questions before we take our last break?
No. No.
All right, excellent. See you guys in 15 minutes. The last little bit we need to talk about for the cardiovascular system is to talk about the blood. After all, we've talked about the heart that pumps it, the blood vessels that carry it. We need to talk about the blood itself. Of course, again, the cardiovascular system is not just the heart and blood vessels, but also the blood that is contained within it. Someone remind me again what tissue type blood is. I did turn on my microphone, right?
Yeah.
Okay, excellent. What type of tissue? If I remember correctly, there are 4 tissue types in my body: epithelial tissues, connective tissue, muscle tissue, and nervous tissue. Does blood fall into any of those?
No.
Connective.
It is indeed a connective tissue. It is certainly a unique connective tissue. What makes it so unique?
No nucleus.
Well, not
Liquid?
necessarily. It's a liquid tissue, absolutely, or what is often known as a vascular tissue. Now, again, obviously there's some confusion on this because, again, you guys didn't all enthusiastically yell connective tissue like you should have. So let's kind of work our way back from this. When defining a connective tissue, what is one of the cardinal characteristics that all connective tissues have? Of course, connective tissues, like all tissues, are made up of cells. But what else was a distinct characteristic about connective tissues?
Matrix.
Exactly. They have some type of inorganic matrix. And that matrix is what helps to define our connective tissues. Remember, with bone, that matrix are primarily calcium salts. In tendons, it is parallel collagen fibers. So let's see if blood meets the criteria for a connective tissue. Does it have cells?
Yes.
Like what?
White blood cells, red blood cells, platelets.
White blood cells, platelets. I heard, and in between the 2, red blood cells. Excellent. Okay, that's a good start. We do have a little bit of an issue though, right? When we think back to 430 and we think back to what a cell consisted of, right? It had a nucleus, it had plasma membrane on the outside, and it had all sorts of organelles inside of it as well. Do white blood cells have all of those things?
Yes.
Yeah, absolutely. White blood cells absolutely have organelles and nuclei, and they're able to divide, and they're able to make proteins, and they're able to do all those types of things. But what about platelets? Are platelets cells, true cells in the sense of what we learned in 430?
No.
No.
No, they're really cell pieces. They came off of a big cell, this big cell called a megakaryocyte that basically has pieces of it ripped off. And so a platelet is really just a little bit of plasma membrane with some chemicals inside of it. So it's not a true cell in that it doesn't have a nucleus, it doesn't have organelles or anything along those lines, but at least it came from a cell at some point. And what about red blood cells?
No organelles, no nuclei.
Yeah, again, at one point in its life, it had organelles and a nuclei, but basically a red blood cell fills itself with hemoglobin, that special protein, so much so that it chucks its nucleus, it chucks all its organelles. So it started as a cell, a true cell, but it isn't when it's mature in our blood. Notice we do still have some true cells. So we still meet the criteria, but it is a little bit of a risky definition. So we do get around that a little bit by, rather than using the term cells when we talk about blood, we instead use the term formed elements. Since all 3 things aren't truly cells, with all three things are formed elements. So if we instead use the term formed element, then absolutely all three things, bing, bang, boom, fall under that category. Now, as Raquan pointed out, this is an anatomy and physiology class. So while this was great for what we were talking about here, are we going to get away with terms like white blood cells, red blood cells, and platelets on a real exam in this class?
No.
No. So
No.
what is the appropriate anatomical term for a white blood cell?
Leukocyte.
Leukocytes.
Excellent. Whoops, I did that. I knew I did that backwards. Excellent. Platelets.
Thrombocytes.
And as Raquan pointed out, what do we call our red blood cells?
Erythrocytes.
Exactly, we call them erythrocytes. Oops, why did that not write? Excellent. So we'll of course use the appropriate anatomical terms for those as well. But at least we've got the first part. So second, matrix. Matrix, of course, as I'm sure we remember from 430, is comprised of a combination of ground substance plus fibers. Do we have such a thing in blood? Is there a matrix for blood?
Yeah.
What is it?
Plasma.
Plasma, absolutely. Plasma, absolutely. Ground substance, after all, is water and the stuff dissolved in it. And as we just finished talking about, plasma has plenty of stuff dissolved in it. Nutrients, ions, waste materials, chemical signals, all sorts of things like that. But then there's that pesky word fibers. Do we have a lot of fibers floating around inside of our blood?
No.
But then it wouldn't be a connective tissue and it would all fall apart. So what's the obvious answer have to be?
Yes.
Yes.
Yeah, it has to be yes, although that doesn't make a lot of sense because if you were to take a drop of blood out of your body and look at it under the microscope, do you see fibers in it? No. But what
No.
happens when you get that paper cut to get that little bit of blood? Does it continue to bleed forever?
Like clots.
Clots. The reason for that is chemical signals cause a special protein called fibronectin, or fibrinogen's another one. These are water-soluble proteins that are dissolved in the blood of our plasma, in the water of our plasma. Chemical signals from platelets, from damaged tissue, can cause them to come out of solution to form that clot. So they're actually in there. We just don't see them because most of the time they're dissolved. So take-home message, absolutely. It is indeed a connective tissue. It has a matrix, it has cells, it has ground substance fibers, formed elements, all those things. So it is indeed, while it is a unique connective tissue, it is indeed a connective tissue. And notice after what we talked about in the last portion of this class, we know there is a massive exchange of water and materials between our blood and our interstitial fluid. Things are leaking out at the arterial end, going back in at the venous end. This constant exchange takes place. So any changes we make to the blood plasma are going to affect our interstitial fluid as well. These two extracellular fluids are tightly linked. As again, we in Sacramento know better than most, because as we've mentioned numerous times, if you were to ingest a massive amount of water in a very short period of time to win an antiquated video gaming system, That could upset the osmolarity of your blood, which upsets the osmolarity of your interstitial fluid, leading to cellular damage, organ failure, and ultimately death. And of course, the study of blood is the field of hematology. All right. So other than grossing people out when they go to horror movies, what is the functions, plural, of blood?
Transportation.
Excellent. We've definitely said that many times. And I think we've already done this once, but let's do it again. Absolutely, the function of the cardiovascular system, the function of the blood is transportation, but of what? Excellent. So I see there one is oxygen, definitely one of the things that is transported. What else?
Gases.
Other gases, carbon dioxide primarily. So absolutely, our gases. What else? Wastes. Say again.
Heat.
Heat. Excellent. What else?
Hormones.
Chemical signals like hormones. Excellent.
Nutrients.
Nutrients. I can think of at least two more really, really good ones. Water. Excellent. Absolutely. Water is one of the important things carried. I think of at least one more obvious one. Maybe you're hesitant because you think it falls under
Ions.
nutrients. Ions,
Mhm.
absolutely. Ions are another big, huge one. Absolutely. And tons of other stuff, right? There's all this kind of stuff that is being transported. And here's the key. Almost all of it. And I really mean almost, let's say almost, is carried by what?
The plasma.
Plasma.
The plasma. Absolutely. All right. What's the exception?
Oxygen.
Oxygen.
There you go. Oxygen. Something like 98.5% of the oxygen that is carried by your blood is instead not carried in the plasma, but carried where?
The heme group. Iron.
Right. Right. Oh, excellent. In the red blood cells. In the erythrocytes. Absolutely. Right. Connected to a heme of part of that hemoglobin, to that iron. Absolutely. So yeah, with that one exception, and even notice there, still 1.5%, not enough to be functionally helpful for you at all, but even still, there's a little bit of oxygen being carried by the blood. The vast majority of everything that is transported by the blood. Excellent. Any other functions?
Immune.
Excellent. It provides part of our immune response. Excellent. Right. Again, we do not have an immune system. We do not have organs working together to provide a defense for our body. We have chemical and cellular interactions that cause that immune response. What portion of the blood is primarily responsible for this?
Leukocytes.
Leukocytes.
Excellent. Anything else? Any other functions?
Regulation.
There you go. Regulation. Absolutely. Regulation of body temperature, regulation of pH, regulation of water, and protection. Not just protection from pathogens, but also maintaining our blood volume, right? What we call hemostasis. Like we talked about, oops. Blood clotting, for instance, to help to make sure we don't lose our blood. Excellent. So 3 huge, big, important functions of blood. Questions on that? Now, of course, if I were to take a bucket of it out of your body, how would you describe those characteristics of blood?
Red and
Viscous.
liquid.
Okay, excellent. I like red, right? But isn't it red and blue?
Yeah.
Yeah?
No.
No? I've got one of each. Which one's right?
Isn't the heme group, isn't that the blue, the iron?
So is it possible to pull blood out of your body that looks blue?
No.
No.
No, because there's no such thing as blue blood. I know it's ironic because every single model that has ever shown blood vessels on them show them as blue and red. But is that really the true color of blood?
No.
The color of the blood is actually caused by oxygen binding to the hemoglobin. So the color comes from oxygen binding to the hemoglobin. Hemoglobin has an iron on it, and that iron molecule, like that Studebaker on your front yard, when the oxygen in the air comes in contact with the iron of your Studebaker's grill, what happens? Chemical reaction takes place and you get rust. Absolutely. And what color is new rust? All right, new rust sounds silly. What color is rust when it first forms?
Brown.
Yeah, it's got a bright red color, exactly. And that's what happens. It turns more brownish red with time, but when it first forms, it's actually brighter red. And that's what happens when we have oxygen-rich blood. Like for instance, if you get a paper cut and a drop of blood appears on your finger, it comes in contact with the air surrounding you. And as a result of it, when blood is oxygen-rich, has lots of oxygen bind to lots of hemoglobin, it takes on a very bright, brilliant red color. I think I asked this question before, but how many people here have given blood before?
I have.
Yeah.
Yeah. Where do they typically take that blood out of?
Arm,
What-
brachial.
Okay. What blood vessel now that we have some understanding of the body?
Your cubital.
Yeah, typically the medial cubital vein. Absolutely. That's the most common one that it is taken out of. And as we know, blood in the vein or median vein is another example. Absolutely. When that blood in a systemic vein is oxygen poor. Not deoxygenated. It is not, it does not have no oxygen in it. It is just oxygen poor. They're, of course, not just exposing it to the air where it can come in contact with the oxygen in the air. Instead, they have those vacuum sealed bags. And when they fill that vacuum sealed bag with your blood, is it blue in color?
No, it's super dark red.
Yeah, it is a dark, dull red. So you are absolutely correct in that the color of blood is affected by the amount of oxygen that is binding to it, but it varies between a bright red and a very dark, dull red. So then the question then becomes, then why is it blue on all of the blood vessels, on all of the models and everywhere else we have looked at it? And the simple answer for that is the refraction of light. Typically in our veins, which as we know are more superficial, as the light is refracting through our skin, it tends to take on more of a bluish coloration. This is especially true in people who are very light in their pigmentation or people who have very superficial veins. You can see that bluish coloration through there. And so that's where the term for the blue blood came from, is just from that refraction of light through the skin. But when you actually draw the blood out into that, again, if you cut yourself, it's exposed to the outside air and it's always that bright red. But when you're giving blood and it's going into that vacuum sealed pack, you can see that it is indeed not blue, but a very dark, dull red color. Exactly. And that's another great way of describing it. It has a metallic taste because of the iron that is inside of it. Absolutely. I heard you guys mention sticky. It is a viscous material. And as we said, chemicals exposed to the air when it is exposed to the damaged tissues starts that coagulation process, making it sticky. What else do we know about blood?
pH around 7.35.
Excellent. Very, very neutral pH. I can think of two more good ones.
The types of blood or group.
Yeah, I like thick. Hold on. Thick and sticky. I like that. I'm sorry. What were you saying? Say that again.
The different types of blood, groups of blood.
True, you are correct. We do have different blood types. However, when you just look at the blood or taste the blood or see the blood, can you tell the blood type just by looking at it or tasting it?
No.
No. So you're absolutely correct. That is an important characteristic about blood that we'll actually talk about on Thursday. We'll actually start, and in fact, you've got a couple lab simulators on that. So yes. So we will talk about that, but I wouldn't say that that's something when you look at the blood you can see. Absolutely, it has a little bit of opacity to it, where it is, you can't, if you had enough of it on a page, you wouldn't necessarily be able to read a newspaper through it. But if you had a thin layer of blood, would you be able to see through it?
Yeah.
Yeah, probably, absolutely. So it has some opacity to it, although it can also be, so it has some opacity, absolutely. And then one more big characteristic I can think of.
Temperature.
Yeah, absolutely. And how does the temperature relate to your body?
Regulates your body temperature.
Yeah, it's typically 2 to 3 degrees warmer than your core body temperature. So again, when it's pouring out of your hand, it has that warm feel to it. Right? Or when someone's exercised and all that blood's come to the surface, you can feel the heat radiating off. Absolutely.
Maybe because of the hemoglobin, the iron as well, possibly.
I'm sorry?
Oh, the temperature being higher than what your body temperature, could that be also because of the hemoglobin, the iron?
No, I would say it's probably because, again, remember that the heat is carried by the plasma. What I would say is that most likely, if you remember how vigorously the heart is pumping it and how rapidly it's moving through your body, a single drop of blood, again, remember, in a single minute, your heart pumps your entire volume of blood through your entire body. So it is constantly moving, constantly in contact with those blood vessels. So between the force of the heart and the friction of the blood vessels, it's typically warmer than our core body temperature. Absolutely excellent.
Is there, I mean, I've heard before that like mosquitoes like certain kind of blood types. Would there be any kind of validity to maybe a different blood type might give off a certain smell or something like that to mosquitoes or any other kind of animal?
I recall hearing about that, but I don't remember reading any research. So I don't remember if it was just anecdotal evidence or if there was an actual study that was done. I don't remember well enough to answer that. Again, I remember hearing that, but I don't remember if that's just, old wives' tale type of thing, or if it is, if it's legitimate, and I don't recall. My guess is that it is unlikely. I know, for instance, there are, I don't want to say nutritional plans because that gives it a little bit too much legitimacy. Quack diets that relate your blood type to what types of foods that you're better able to metabolize or eat or things like that. As we will talk about on Thursday, your blood type is solely determined by proteins that are expressed on the surface of your red blood cells. So I would say that it is unlikely that that might be a characteristic that could be determined by a sense of smell, even something as, you know, specific as a predator like the mosquito or something like that. But honestly, I don't know for certain. I think it's unlikely, but is it possible? Potentially.
Like you said, it's unlikely, but I would say it comes out like how warm is your body is.
Sure, temperature or something like that could certainly be something that would have more of a.
It's about your skin too. Like if your skin is like really like rough and they cannot just take blood from it, they're just gonna go and see a smoother skin.
Sure. By the same token, the amount of hair you have on your arm could be something that could affect it as well. Again, I'm not familiar enough with the research to be able to say. It's not an area that I've studied, but are all of those things that could potentially? Sure. So is it possible that a blood type could? Maybe. I think it's probably less likely than other characteristics, but I can't say no because I don't know. And I've heard that saying as well. So there may be some, you know, legitimacy to that, but I can't say one way or another. All right, excellent. Great questions. All right. So as we mentioned, a mass amount of our body weight, about 60% of our body weight is water. Of that body weight, about 8% is our whole blood. And our blood is basically about 55% blood plasma and about 45% of those formed elements, the erythrocytes, the leukocytes, and the thrombocytes. We can see that distinction by taking the blood and putting it in a centrifuge. And as you spin it dramatically, what you will see is that the blood basically separates into three distinct regions. The lightest stuff, which is basically the water and the solutes dissolved in that water, form on the top, and that is basically the plasma. And then as you can see underneath that, there are two distinct layers beneath that. The smallest of those, making up a very small percentage of the formed elements, are the leukocytes and the thrombocytes. And this thin, narrow region is what is often referred to as the buffy coat. And the biggest component of our formed elements, the largest segment, is then those red blood cells, the erythrocytes, that make up the vast majority, something crazy like 99% of the formed elements are those erythrocytes. So again, those formed elements and the plasma for that matter can be divided as well. As I mentioned, and again, another pretty picture from your textbook showing all of this as well. As I mentioned, plasma makes up 55% of the blood, and the majority of it is water, about 92%. The vast majority of the remaining components of our blood plasma are plasma proteins, water-soluble plasma proteins. There are several of these. Albumins is by far the most common. Albumins basically play two main roles. First, let's say it this way, it both directly and indirectly affects osmolarity. Remember, osmolarity is the volume or the amount of stuff in water. Let's say, for instance, I had 2 beakers filled with water. Each of them contained exactly 1 liter of water. Into one of them, I put 1 mole of glucose. And in the other one, I put 1 mole of sodium chloride, table salt. Would these two solutions have the same osmolarity?
No,
Why not?
the glucose is bigger.
Okay, true. Glucose is bigger. So does this have the, this is bigger. So is it this first beaker, beaker A, that has the highest osmolarity?
Yeah,
Everybody else agree?
Isn't mole different from molecule?
Well, mole is just a number. So if you don't like mole, then let's go even simpler than this.
I thought they are the same because mole is
Okay, so let's make it even easier. I put 100 glucose into this side, and I put 100 table salt into this side. A mole is basically just Avogadro's number, right? But let's use an even simpler number. I put 100 glucose on this side and 100 table salt on this side. Is the osmolarity the same or different?
Different. Sodium dissociates into sodium and chloride.
Exactly. Remember, osmolarity is a measure of the amount of stuff. You are correct. Glucose is bigger, but this is still just 100 things. Yes, they're big things, but there's 100 things in this water. As someone, and I apologize, I didn't see who it was that spoke, but as they mentioned, when you put that table salt into water, remember table salt disassociates. So you're going to have 100 sodium ions and 100 chloride ions. So how many total things are you going to have in this water?
200.
200. So notice the osmolarity in beaker B is actually double what it is in beaker A. Yes, the mass of the glucose is far bigger than the sodium and the chlorides, even combined, let alone by themselves. But it's not a measure of the overall mass. Osmolarity really is just a measure of stuff. So albumins in and of itself is just stuff. A large amount of stuff. And so that directly affects osmolarity. But we didn't talk about what albumin does. Albumin is an important chemical signal that actually tells the kidneys to reabsorb sodium. And if we tell the kidneys to reabsorb sodium, what happens to the amount of stuff in our blood?
Reducing.
If it tells the kidneys to bring it back, to not let it go out in our urine, is there more stuff in our blood or less stuff in our blood?
more.
More stuff. So notice this allows us to have more stuff in our blood. And if we have more stuff, we have more osmolarity. So notice albumins, as I mentioned, both directly and indirectly affects osmolarity. It affects how many things we have to count inside of our blood plasma. And osmolarity is definitely important. Another important blood plasma protein are our globulins, in particular our immunoglobulins. That may not be a term you're familiar with, but I guarantee with 100% certainty, you know the other name of an immunoglobulin. What else are immunoglobulins known as?
T cells?
Close. Not T cells.
B cells?
Getting closer. They're not B cells themselves, but they're the things the B cells make. Come on, I know you guys know, even if you don't know, you know. What's the other fancy word for an immunoglobulin?
Is it the lymphocytes?
No, it's a protein, remember. Happens to be a Y-shaped protein, something a lot of people have been counting in their bloods a lot as of recently. There you go. Frequan's got it. Antibodies.
Oh,
Like I said, you may not have heard the term immunoglobulin before, but all of you have heard of antibodies. Absolutely. Antibodies. Immunoglobulins are antibodies. Just another fancy word for it. As we talked about, we have our water-soluble proteins like fibers, like fibrinogen, that again are going to come out of solution and help us to clot that blood when the time is present. And again, notice that makes up 99% of the stuff. Outside of the proteins, we have all sorts of other things like our electrolytes, nutrients, hormones, gases, urea, yammer. Your book's got a nice table that talks about all the different things that you can find inside of the plasma. Again, I don't think it's as important to memorize this, but know the basic components of what's in the plasma. I think, but what the plasma does for us is a little bit more important. What I want to finish with, though, is by talking about our formed elements, our erythrocytes, our leukocytes, and our thrombocytes. Which ones were the erythrocytes again?
Red blood cells,
Red blood cells.
Leukocytes are
white blood cells.
white blood cells. And notice there are 5 main types. And they come in 2 flavors, a granulocyte and an agranulocyte. And what do you think the difference between a granulocyte and an agranulocyte is?
Size.
Size isn't a bad guess, but with a name like granulocyte and agranulocyte, what do you think is the big difference?
the
They
presence
do
of
not have granules.
Yeah, one has granules and the other one does not have granules. There you go. And it turns out of our 5 main types, 3 are granulocytes and 2 are agranulocytes. We'll talk about those in a bit. And we have to talk about both thrombocytes and the cells that make them. And remember, I told you there's a megakaryocytes. Are the cells.
Dr. Slusky,
Yes.
not to digress, but the Latin word for site, if that's Latin, does that refer to small cell?
I'm sorry, say that again.
Oh, regarding site, regarding the meaning.
Oh, sites.
Oh, that's Latin or not, but does that refer to small cells?
Great question. Typically, the term site is used to refer to a mature cell. If you remember back in 430, immature cells are typically referred to as blasts. So you may have, for instance, a osteoblast was the cell that makes the bone matrix, whereas the osteocyte is the mature cell that maintains the matrix. So it's a great question. I'm not sure what the site probably is Latin. I don't know what it stands for, but the way it's typically used here is in terms of being the mature cell. However, again, as we know, anatomists hate us and they mess with us a little bit because as we know, thrombocytes are not really true cells. They're really just cell pieces. And so you could argue that the use of the term site in the thrombocyte isn't an accurate description from a mnemonic standpoint, but it's the term they use. But yeah, typically sites we use to refer as to the mature cells. Did that answer your question? Maybe not satisfactory, but at least answer it.
Yes.
Okay, excellent. All righty. Perfect. All right, let's finish by talking about some of the basic anatomy of our erythrocytes. Erythrocytes by far are the most common formed element. And it's not even close. In a single drop of blood, a single microliter of blood, there is something on the order of 5 million red blood cells inside that single drop of blood. Now, I'm not the one that sat around and count them, but I'm not going to check their work either. So I'll take their word for it when they tell us that. When we look at our red blood cell, notice it has a very distinct shape. That distinct shape is basically like a donut where the hole hasn't been punched through. And we actually describe it as a biconcave shape because it has two concave surfaces on each side. What is the advantage of this type of organization, this type of a shape to this cell? Notice.
Surface area.
Excellent. Again, remember the job of this is to carry and release oxygen and some CO2 as well, but primarily oxygen. As we know, 98.5% of the oxygen that is carried by your blood is carried here. So I want to be able to carry and release it. So absolutely having a huge surface to volume ratio helps immensely. So again, that gives it a big, huge surface area for the exchange of materials. But I did say advantages, plural. Any idea what another advantage of this shape might be?
It's able to carry a lot of hemoglobin, inflate.
True, although you could argue if it was a big ball, you could have even more hemoglobin in it. We would have the issue of surface area at that point. But if the goal was just to contain as much hemoglobin as possible, a ball would do that much easierly. We'll pretend that's a word.
Is it to pass through vessels?
Yeah, it's what gives it a small flexible shape, which allows it to move more easily through our capillaries. Remember, as we mentioned, the capillaries are so small that these red blood cells need to basically line up single file to get through them. And so that's a real challenge. In fact, if you think way back to 430, one of the things we talked about, we'll talk more about hemoglobin in just a minute. But if you remember, hemoglobin is a big globular protein where if one single amino acid is mixed, a single mutation that changes one single amino acid, when that hemoglobin gets into a low pressure environment, what ends up happening is that hemoglobin unfolds and becomes long and linear. And as it becomes long and linear, it pushes on our red blood cell, causing it to elongate, causing it to form this kind of elongated curve shape. And what do we call that condition?
Sickle cell.
Sickle cell anemia, absolutely. This causes these red blood cells to become more congested in those capillaries, making it harder to release oxygen and nutrients. It can actually cause the red blood cells to burst, releasing all of that hemoglobin into the plasma, which again can congest capillaries, can change the osmotic pressures, affect diffusion. Sickle cell anemia is a condition that affects small capillaries. So tips of the fingers, the retina of the eye, areas like that. It can be very painful, very damaging in this process because of that. So yeah, that biconcave shape helps it in its movement through those capillaries. And again, as I mentioned, it is primarily involved in the transportation of oxygen. Again, as we mentioned, something like 98.5% of all the oxygen that is transported by the blood is located here in the red blood cells. And it's filled with hemoglobin, but that hemoglobin does a couple other things as well. Hemoglobin can actually play a role in the transportation. Let's say it this way. of carbon dioxide. I think something like, I don't remember the number, 15% or something like that of the carbon dioxide that is carried by your blood is carried in your red blood cells. So it binds some of it. One of the important things is oxygen and carbon dioxide are not fighting for the same binding site. So they're not competing for the same binding site. They can influence each other, but they can both bind to the hemoglobin at the same time. The example I always think about are my two children. I have this nice big couch that 3 people could easily fit on. However, if one of my daughters happened to be sitting on the couch, what is the chance that the other one will sit down as well?
Highly.
Highly? Well, you got better kids than I do. Most of the time, every once in a while, they'll be nice with each other. But most of the time, if one of them's on the couch, even though there's plenty of room for the other one won't sit down, right? It makes it less likely for them to want to sit down, right? They'll go to the love seat or to the, recliner or someplace else and sit. They don't want to sit on the same couch together, all bundled up next to each other.
I guess I'm thinking of my son who just wants to torture his sisters.
True, but have they hit high school yet?
Yes.
Oh, okay. Well, see, I got 2 girls, so maybe it's different with the boy. Yeah, so I probably would have done the same thing to my sister. Not only would I
Oh, no,
sit down on the couch.
he wants to sit. He wants to sit there and annoy them.
Yeah, exactly. So yeah, so they one will be spread out as much as they possibly can on that couch to discourage the other one from sitting down. So it's the same way here. Oxygen can discourage CO2. CO2 can discourage oxygen, but they can both bind at the same time. And
wasn't there like a disorder that we talked about last in 430 where the CO2 binds to it and you look like bluish? Or
you're thinking of carbon monoxide.
Oh, monoxide. Never mind.
Carbon, you're absolutely one of the things that makes carbon monoxide so dangerous is it binds to the oxygen site and it binds with a higher affinity. And what does that mean to bind with a higher affinity?
Wants to bind there more.
Yeah,
stronger.
If both are competing, it's going to be more likely to win and it's not going to want to let go. So yeah, it kicks the oxygen off. And that's the problem with carbon monoxide poisoning. If you load up your hemoglobin with carbon monoxide, is the 1.5% of oxygen that's dissolved in your blood plasma going to be enough to give your tissues of your body what they need? No, absolutely not. And so you're going to get deprived of oxygen. And so tissues like nervous tissue, like cardiac tissue that are highly sensitive to oxygen levels can be rapidly damaged by that carbon monoxide poisoning. So yes, we were talking about carbon monoxide, not carbon dioxide. 2 very, very different beasts. Oh, I got sidetracked. Last thing, it also contains some important enzymes that facilitate a bunch of important metabolic chemical reactions. So this hemoglobin inside of our red blood cell is very, very important. All right. Questions on that?
Professor, I know the erythrocyte is not a true cell, but does it have a plasma membrane?
Yes. Yeah, basically, by the time it is a mature erythrocyte, those are the 2 things that pretty much all it is. It has its plasma, well, that's horrible. It has its plasma membrane in its biconcave shape, and it's just chock filled with hemoglobin. That's basically what it is. It's basically just a big bag of hemoglobin.
So the oxygen diffuses into the cell and then binds to the hemoglobin?
Exactly. It diffuses in and binds to the hemoglobin and then can be released by the hemoglobin as well.
Thank you.
Yep. Looks like Samuel's got another great question. To answer your question about carbon monoxide poisoning, obviously you want to get away from the carbon monoxide. so that it can be expelled, but usually that's not enough. So what they do instead is they put you into a high pressure environment. So they put you in like one of those pressure tanks where they can fill it with very, very rich oxygenated air. And basically what we try to do with that hyperbaric chamber is to force more oxygen into the blood. And if we can increase the pressure of the oxygen into the blood, we can get oxygen to finally get a strong enough affinity where it's able to push that carbon monoxide out of it. So we basically overwhelm the hemoglobin with so much oxygen that we're able to force that carbon monoxide off. And so that's
Like a scuba diver kind of thing, the bends.
It's similar it is similar in that you're using a hyperbaric chamber to put more pressure on gases to get those gases to dissolve into the blood. Yes. So it is similar in that fashion. And we will actually talk about that when we get to the respiratory system. All of these things, because they all relate. All right, we've talked about hemoglobin. Hopefully you talked about it in 430. Here we see the quaternary shape of this. Notice it is made up of 4 subunits. 2 of those are beta subunits. 2 of these are alpha subunits. These subunits have this globular shape to them. And notice both alpha and beta subunits have this special segment at the center of it, what is known as a heme group. Here is what the heme group looks like. And no, I'm not going to make you draw this and recreate this and recognize the nitrogen and carbon rings that are forming this or anything along those lines. But as we were talking about, the one big important thing that we did discuss here is at the center of this, we have that iron atom. And that iron atom attracts oxygen. But unlike that Studebaker on your front yard, once the oxygen binds to the iron there, is it easy to get the oxygen off so that it becomes iron again and the rust goes away?
No.
No, exactly. It's not a trick question. Rust doesn't go away. However, the big key to here is that here our oxygen reversibly binds. It is able to bind to the iron under some environments and then able to release in others. And like I said, we'll talk about this in much more detail when we get to the respiratory system. But the key is it can bind to it and let go. And that's how it's able to be transported throughout the body and then released to the parts of the body that need it. There you go. Strongly but reversibly binds to the oxygen. And like I said, there's also a binding site for the CO2. But unlike the oxygen that binds directly to the iron, CO2 basically binds out here on the outside of the heme. So again, they're not fighting for the same spot. And I'm not kidding when I say that a single red blood cell is basically a big bag of hemoglobin. Again, I wasn't there. I wasn't the one with the abacus that sat down and did the counting, but I am told a single red blood cell has 280 million hemoglobin inside of it. Now, each hemoglobin, remember, has 4 binding sites. So each of those hemoglobins can bind 4 oxygens.
How much oxygen do the cells use?
A lot. But you get the right idea. When we're thinking of real life numbers, it's astronomical. So a single red blood cell, 250 hemoglobin, each one that can bind 4 oxygen. And then on top of that, a single drop of blood has 250 million red blood cells in it. So a single drop of blood can carry how many oxygen molecules?
1.12 million. oxygen.
That's per red blood cell. But then you have to then calculate that times the 250 million that are in a single drop of blood. Don't do the math on that. It's just a ton. It is a crazily.
7.34 billion.
How much?
7.34 billion.
Wow. So there you go. So that's like crazy. So yeah, so when we're talking about how much oxygen the blood, our tissues need. In fact, we don't even talk about absolute numbers of oxygen. What we'll actually talk about when we get to the respiratory system is actually the partial pressure of oxygen and how much oxygen is moving that way. So when we talk about it, the pressures of oxygen moving, we don't have to talk about absolute numbers because the absolute numbers are ridiculous when you're talking about these kind of numbers. All right. Now, as I mentioned, your red blood cells make up over 99% of your formed elements. So when we talked about our blood being 55% plasma and 45% formed elements, really, that's pretty much the same thing as saying that it's 45% red blood cells, right? Since they're making up the vast majority of it, and they give a fancy name to this value. How many red blood cells you have for carrying oxygen is known as the hematocrit. In general, it's about 45, but notice there are some slight differences in sex. Females, the average is 42. Males, the average is 46. And again, why the big difference?
Mass size. Muscle
Yeah,
mass.
exactly. As Erevic said, it's because males are better. Exactly. Excellent. All right. Questions on that? No, you're right. It probably has something to do with muscle mass or something.
Sorry, I missed that part. What was it?
What?
What was the different? Why is it different?
Well, I'm not the one who said it. Erevic said that it's because males were better, but I'm pretty sure she was wrong on that. No, again, it's one of those things that mathematically is statistically significant, but it's really not significantly important. Because again, is it going to be the same for everybody? No, that's the point I'm getting to. There are so many factors that make this different. Height is my favorite example. If you look across the entire population of the planet, right, males statistically are taller than females. But even in a class this big, where there's just 27 of us, is every single male taller than every single female in a class this size?
No.
No. So even in a class this size, that mathematical statistic about height isn't meaningful. It's significant from a math standpoint, but it's not significant from a function or a structure or a practical standpoint. And this is another perfect example of it. My guess, as is mentioned, is it may have to do with differences in muscle mass versus adipose mass or something like that, or it could simply be a matter of size. Since males tend to be a little bit bigger, that means they may have more blood vessels, so further distances they have to travel. So maybe as a result of that, because there's an increased resistance, they need more red blood cells to compensate for it or something like that. But as I mentioned, even in a class as small as this, is every single male's hematocrit going to be bigger than every single female's hematocrit? No. So again, these numbers are silly and meaningless, right? We have more plasma than we have blood. And again, these are definitely not numbers you need to worry about memorizing. This is a little more important. And what's even more important is the significance, what they mean, why these numbers are important. Why these numbers are important is they basically tell us how much oxygen the blood can carry. That's really the point of the hematocrit. The hematocrit gives us some idea of how much oxygen the blood is able to carry. because if you're not able to carry enough oxygen to meet the needs of the body, well, we have a fancy name for that condition. The fancy name we have for that condition is to say you're anemic. But even with anemia, there are different factors that can cause it. Some could be not having enough red blood cells, or you could not have enough hemoglobin molecules in your red blood cells, or you could be producing less functional hemoglobin. I think there's something like 8 different major classes of anemia, but all of them basically mean the same thing: how effective you are at being able to deliver oxygen. And we talked a little bit about this in the last class as well, if you remember, right? The more oxygen you can carry in your blood, the more efficient you will be at producing ATP. So we talked about the example of how these, iron deficiency is another great example of a type of anemia. Absolutely. We talked about those distance endurance athletes like cyclists who would take a pint of blood out of their body a month before their race, let their body build back those red blood cells, and then the night before the race, they pump all that blood back into their veins, dramatically increasing the number of red blood cells, meaning that they're able to carry more blood. And it's completely illegal, and it's cheating, and it's bad for the heart and everything else. However, there are some ways that endurance athletes can do that, can increase their red blood cells without blood doping. How do they typically do that? Anybody know how those endurance athletes prepare for that Tour de France?
Yeah,
they
they
practice
go
at
to
a-
a higher elevation.
Yeah, they go to higher elevations. They go to higher elevations to train. Again, maybe you've never been an endurance athlete, but down here in Sacramento, close to sea level, you have no problem carrying your 2 bags of groceries up the 3 flights of stairs to get to your appointment. To get to your apartment when you're done shopping at the end of the day. But you go up to Tahoe for the weekend, and just walking up those 5 stairs to get to the casino, and you're exhausted. Why? Because at elevation, there's less atmospheric pressure and the air expands out. So when you breathe in, less oxygen actually gets into your lungs. And so what happens when less oxygen's in your lungs, there's less oxygen to deliver to your body. And your kidney says, uh-oh, hey, we're not getting enough oxygen. We need to make more red blood cells. And so they go up there and they train for 3 months before a race, and training at elevation is going to naturally increase the red blood cell count. And so typically when they're measuring the blood on these endurance athletes, it is almost always above 45, but there is a critical limit. If you're above 52% or whatever it is, right, then you get disqualified. There's some number, I don't know what it is, but that's the point. You do see for a while there, I haven't seen it as much, obviously, because the world practically ended. But one of the things that was pretty popular before COVID came around is you would see people wearing these masks that when they worked out that had a restrictive airflow. So that when they worked out, they were getting less oxygen and thought they were doing the same thing. However, to really increase your red blood cell count, you can't just do it when you're exercising. You have to wear that thing all the time. To really restrict your oxygen levels, to really kick your kidney into making you more red blood cells. And most of the people that I saw only wore them when they were exercising. And so it looks cool, I guess, but didn't do much. But now we get to wear masks all the time. So all of our hematocrits should be going up. All right, except they're not depriving you of oxygen, so it won't. All right, tangent, bad joke, questions on any of that?
Yeah, is there a reason why like somebody who would be anemic would like eat ice chips, like be drawn to eating ice, I guess would be.
Not that I'm aware of. I always thought chewing on ice was a sexual frustration thing.
I mean, I heard it's like for somebody who's anemic or iron deficient, they will eat ice.
I mean, I guess if you're like getting well water or hard water, there might be minerals in it that, I mean, the same way that when someone's anemic, they might, crave something like red meat or like liver or something like that. So maybe, but I can't think of a mechanism offhand that would just ice in general, especially now since most ice comes from, refrigerators where it's been filtered. Again, I'm not gonna say no, but I have not heard of that. Yeah, pica is a very common condition with pregnant women, but I haven't heard of that with iron deficiency. But again, it's not my area of expertise, so I will not say no. I'll just say that I'm not familiar with it. All right. All right, excellent. So that is our hematocrit. And again, the importance of that number. How are we on time? Perfect. Last thing I want to talk about is, again, one of the issues we have with these mature erythrocytes that they're not true cells. All right. Don't have nucleus. They have almost no organelles. So they have no ability to make proteins. If they can't make proteins, they can't repair themselves. They can't divide. They can't do anything. So not surprisingly, they don't last very long. They last from about 100 to about 120 days. It is an incredibly eventful 120 days. During that period of time, they travel about 700 miles. Easily get from here to Disneyland in that time. But as we talked about, it is very important to maintain the appropriate number of cells. Now notice when we use this phrase here, hematopoiesis, or it's sometimes also referred to as hemopoiesis. Oops. We are talking about the formation of all blood cells. This means leukocytes, erythrocytes, and the megakaryocytes that make our thrombocytes. Of course, in an embryo, that pretty much happens everywhere. The yolk sac helps to make red blood cells. Our liver and spleen play a role in that. Our thymus is maturing white blood cells. Our lymph nodes can actually be forming them. And then, of course, red bone marrow, which is pretty much everywhere in that adolescent. But do we have all these things to make it when we're an adult?
No.
No. Where do we find the red bone marrow in adults?
The heads of long bones.
Excellent. Primarily the heads of our long bones. Anywhere else?
The center of our irregular.
Yeah, our red bone marrow is located in the heads or the epiphyses of our long bones. I guess we should be more specific. Of our long bones, and in the, in the red bone marrow inside of our short, irregular, and flat. And let's say most, because there are, and in most short, irregular, and flat bones in the center. Exactly. So that's the places where we find our red bone marrow. Now, as we talked about in 430, we have these pluripotent stem cells. Someone again remind me what a pluripotent stem cell is?
Able to form more than 2 kinds of cells?
Well, 2 or more. I think I like that.
2
That's
or
good.
more.
Yeah. So this is a stem cell that can produce 2 or more. Or let's even go a small range of cells. All right. So these are stem cells that can't become everything. These hemocytoblasts in our red bone marrow can form any type of cell associated with the blood. But they can't form toenail cells, they can't form eyeball cells, they can't form liver cells or anything like that. And this hemocytoblast, yeah, exactly. That great comment. Absolutely. That's kind of the definition of a stem cell. A stem cell, if you remember back to 430, basically has 2 requirements to it. The first is that it's an undifferentiated. What does that mean again? What does it mean to be undifferentiated?
It's unprogrammed. It can be anything it wants to be based on its environment.
Right. Well, it's not that it can become anything, but you have the right idea. It's unprogrammed. It doesn't have a job, right? It doesn't have a specific function. It's not specialized. Exactly. Right. It's like a millennial. Doesn't have a job, right? Just sitting around. But the one thing that our stem cells are capable of doing is undergoing rapid mitosis. So 1 cell becomes 2 cells, and you absolutely have the right idea. Typically what happens when 1 cell divides to become 2 cells, wow, that's way too big. So we have this stem cell. It divides to produce 2 cells. One of these cells is going to go off and become something like a red blood cell or a white blood cell or the cell that makes platelets. And the other cell that is made basically stays a stem cell. So as Frequan pointed out, these basically self-renew, they replace themselves. They make a new cell. And then we started with 1 stem cell, we end with 1 stem cell, but now we have some new cell that can become something fun. And here is the pretty picture that shows this process. Notice down here, and I know in fairness, we haven't talked about all the names of these things yet, but notice here we have our erythrocyte. Here we have our thrombocytes, which remember I said were made from those megakaryocytes. And here we have our 5 types of leukocytes. 3 granulocytes, 2 agranulocytes, the different types. And notice all of them start as a hemocytoblast. In fact, the way we would describe this is the hemocytoblast is the primary stem cell for all formed elements. Which is going to be really convenient on the lab exam. Because if on the lab exam, I point at a formed element in the blood, and I ask you to identify its primary stem cell, do you even need to look at what cell the arrow is pointing at?
No.
No, because they're all the same. All of them come from this pluripotent stem cell this pluripotent primary stem cell. Now, technically, when a hemocytoblast divides, how many different things does it immediately form?
Two.
Basically just two. Those two things that it can potentially form are the myeloid stem cell and the lymphoid stem cell. These two stem cells are both stem cells, but we are going to refer to these as the secondary stem cells. So if on the lab exam, if you see a drop of blood or a model or an illustration with an arrow pointing at a formed element, and I ask you for the secondary stem cell, how many possible right answers are there? Two. So if you don't know, flip a coin, guess. Right? But notice one more thing. These are both stem cells. Again, remember what that means. They are undifferentiated and they divide rapidly. And lo and behold, our myeloid stem cell is a pluripotent secondary stem cell. But what about the lymphoid? Is it pluripotent as well?
No.
No.
Notice it's a unipotent. Notice if this hemocytoblast divides to produce a lymphoid stem cell, how many possible things can it become?
Lymphoblast.
Just one. The
One.
only thing it can become is a lymphocyte. You're right, first a lymphoblast, but ultimately its ultimate destination is a lymphocyte. Right? How many things can our myeloid stem cell become?
6.
6. It can become a red blood cell. It can become the cell that makes the platelets, and it can become 4 of the 5 possible leukocytes. Notice the one thing it can't become is a lymphoid. So again, good news is if I ask you for a secondary stem cell for a formed element, yes, you got a 50-50 chance, but which one should you probably guess if you don't know?
Myeloid.
Yeah, unless you can tell for certain it's a lymphocyte, guess myeloid. Myeloid. Now, we will walk through these paths a little bit and talk about these processes and how we get here. But I will make one more quick statement before we do that. How? How do we determine which path the cells take? How do we get at one moment in time that hemocytoblast to give us a red blood cell, and the next time it gives us a monocyte? How do we make this? How do we determine which path the cells take?
I need.
Okay, but how do we tell the hemocytoblast what we need?
Hormones.
Yeah, you guys, absolutely. Hormones and other chemical signals are how we determine which of these paths we're going to take. And if you look closely at the illustration, they've kind of shown that to us. Notice, for instance, right, they have all these bubbles, and these bubbles basically indicate the chemical signals that are telling them, these cells, what to do. So they've kind of given us that hint of what that is. And we will talk about some of these as well. I will warn you right now, we are going to focus primarily on this pathway, the one associated with the erythrocytes. We'll talk a little bit about the other pathways, but this is the primary pathway where we will spend most of our time talking, where you need to know the intermediate steps. Most of the intermediate steps for this stuff, you're not going to have to worry about. But this one we will. So we will simplify this picture a little bit.
Professor, on the lab exam, for the blood material, do you have a list or?
That's what we're going over right now. But the short answer. Hold on. So that's the stuff we're going over right now. All right, so it's the stuff we're talking about in lecture today and on Thursday. But on the exam, could I have a picture like this with a bunch of formed elements on it and an arrow pointing at this? And if you think about it, I could have it. No, that's arrow's horrible. Notice now there are basically 4 questions I can ask. Identify the formed element.
Red cell.
Erythrocyte.
Erythrocyte. Remember, red blood cell, I'm going to consider a spelling error, and you'll only get partial credit for that. Identify the function of the formed element.
Carry oxygen.
Transportation of oxygen.
Yep, perfect. Excellent. Absolutely correct. Identify the primary stem cell of this formed element.
Hemocytoblast.
Excellent. Identify the secondary stem cell of this formed element.
Myeloid stem cell.
Myeloid stem cell.
There you go. Just that easy. Now, obviously, we haven't talked about the other formed elements yet, but by the end of the next class, we will. And so you'll be able to answer those 4 questions just as easily for those as we did for the one we talked about today.
Is the platelets that little purple one, or is it like little specks?
No, yeah, this thing that looks like a little piece of dirt on the slide. Yeah, that, again, those thrombocytes really are just pieces of plasma membrane. Basically, the arms and the legs of the megakaryocyte are ripped off, bundle up, and so they're a little bit of plasma membrane with some chemicals inside. And yeah, so that little piece of chewed up looking chewing gum thing, that is indeed our thrombocyte. And then notice one of the things I love about this picture, I like to believe that this is a real picture, because if you think about it, with all the scientists all looking at all of the microscope slides from the beginning of time till now, this has probably happened. So I don't know for certain, but I hope this is a real picture. But what's cool about this particular picture, and the reason I use it during our lecture, is this particular picture shows all of the formed elements in one field of view. So yes, could it be possible that somebody made this? Maybe. But I'm hopeful that's not the case, but it's possible that that's what happened. But I'm going to pretend that it's real. And more importantly, it allows us to see all the formed elements and talk about them. But like I said, we've only done erythrocytes so far. We have to talk about the rest. And we're not even done with erythrocytes yet either, because we will go through that pathway. All right, but I think this is a good stopping point for here. So any questions on this?
Is that the pink right top one, eosinophil? And do we have to know it?
Yes, like I said, if you look at the lecture slides, you'll see we're going to go through all the rest of these. We haven't yet, but remember, we still have lecture on Thursday. So on Thursday, we're going to finish our discussion of erythrocytes. Then we'll talk about the leukocytes. Then we'll talk about the thrombocytes. And then to finish things off, we'll talk about some blood typing, as well as hemostasis. So we still have a fair amount to cover on Thursday. So yes, so we definitely are not done with our discussion of blood and its formed elements yet, but we will absolutely get there. And yes, to answer your question, that one does happen to be the eosinophil. And yes, you will need to know it, be able to know why you recognized it, and know its function. But we haven't gone over that yet, so it's okay if you don't know that today.
And the exam will cover everything up until Thursday.
Yes, yep, everything up through Thursday will be on the exam. Absolutely.
Professor, for the lab exam, will you also be asking like parts of the pathways, like normal blasts and reticulocytes?
So yes, as I mentioned, we will go through that process for the erythrocyte, for the red blood cells. We will talk about the intermediate stages, and you'll need to know the names, and you'll need to know the process and why, what's happening, and what's happening and why, and all of that. We will not go in as much detail for the thrombocytes and the leukocytes. So for those, you need to be able to identify the cells, you need to know their functions and which primary and secondary formed elements they are, but you don't need to know the name of any of the intermediate stages. For the red blood cells, we will go through the intermediate stages.
Got it. Thank you.
And again, look at the lecture slides. The lecture slides show you the things that we're going to be talking about. So it is there, and we definitely will be emphasizing that. But yes, the short answer to your question is you don't need to know any of the intermediate stages for the white blood cells and for the platelets, just for the red blood cells. And that's exactly where I'm pretty sure that's where we're starting. Oops, wrong button. Where was we? We was here. Yeah, exactly. So you notice the very next slide are the stages of the red blood cell. We are now going to talk about at the beginning of class on Thursday, not just hematopoiesis, but specifically erythropoiesis, the formation of red blood cells. So absolutely, that's exactly where we're going to start on Thursday. All right. Any other questions?
No question regarding the exam.
Yes.
I mean, all the material is all interwoven, but are you going to have emphasize certain sections, certain topics? Or are they going to be equally weighted in terms of the topics we've covered?
Great question. Okay, so absolutely all the information is interwoven. Even when we're in the classroom, if you think about it, lab and lecture are really just different modalities for learning the material. And when we're all online, that line is blurred even more. Yes, lab exams tend to lend themselves more to identification. But as I mentioned, while on the exam, I could point at this cell and ask you to identify it what it is. At the exact same time, I could ask you to tell me what it does. Right? So function is just as important as identification, although lab exams tend to lend themselves better to identification. And lecture exams are definitely better processes, right? And identify the process of this or the process of that or capillary exchange or something along those lines. But could I ask an essay question on the exam where you have to identify and describe the main types of leukocytes? Yeah. So yes, absolutely, the information is interwoven that way. As far as emphasis goes, one of the things that I've said many times in this class is one of the things that I love about anatomy and physiology is that this class is hard. So I don't have to be tricky. So the more time we spent talking about a topic, the more important that topic likely is going to be. Now, I would say the one exception to that is, again, the anatomy. Obviously, we only spent a little over an hour talking about some of the blood vessels in the body, but obviously those blood vessels are going to make up a huge part of your lab exam just by looking at your study guide and seeing the numbers of them. So obviously that's going to be a big part of the exam that way. But when it comes to processes or things that have steps or things like that, then yeah, absolutely, there will be the more time we spent on something, or or like again, I think I've made it pretty abundantly clear that you're going to have to calculate net filtration pressure on the next exam, right? I don't think that should be a surprise to anybody because we spent so much time on it today, and I gave you some huge hints towards it. And quite frankly, I don't care that I'm telling you that it's going to be on there because I still understand you need to study it. You need to show me your work. And so again, I don't have a problem doing that. And it should be just as easy with other concepts, with things that we've covered, things that have had processes, have had steps to them. Those are the things that are going to be essay questions. There are not more multiple, well, okay. There are obviously more multiple choice questions than essay questions. The multiple choice questions will somewhere between 25 and 35 multiple choice questions. And you're gonna have somewhere between, 6 and 9 essay questions. So yes, there are more multiple choice questions than essay questions. However, the points for the essay questions are going to be worth more than the points for the multiple choice. I know essay questions are something that a lot of people aren't as comfortable with, but what you have to remember about multiple questions is there is some, pardon me, you have to remember about essay questions is there's something very, very magical about essay questions. And that magical thing about essay questions is partial credit. With a multiple choice question, a multiple choice question really doesn't show knowledge. Because multiple choice questions almost by definition are tricky. Because if they were completely straightforward, all their answers would be totally obvious. So when they write multiple choice questions, they almost by definition are tricky, right? There's some catch, some word, some phrase or something where if you misread it, you're going to misinterpret that question and they're going to have that trap answer there to catch you. You could totally own a concept. Hell, your uncle could have been the one that described it. You could have had your picture taken with it, but you misread one word on that multiple choice question and you get it wrong and you don't show me any knowledge. That doesn't happen on an essay question. Yes, if you know all of the information and give me all of the information, you will get all of the points on an essay question. But even if you just know some of the information, you will still get some of the points. So there with an essay question, the more you know, the more you write down, the more points you're going to get. That shows true knowledge. So yes, because of the nature of the class, I would love nothing more than to challenge you with 12 essay questions and have that be the exam. But quite frankly, I don't want to have to grade them. So yes, because of the nature of the class, you get a mix of multiple choice questions and essay questions. But the multiple choice questions are not worth more than the essay questions because the essay questions is where you show me that you understand the information. All right. And again, details. Know it in your brain doesn't do me any good unless you write it on the paper. Be specific, be descriptive. Use the correct terms. Remember to put artery and vein. Remember to put left and right. Like I said, there's nothing I hate more on a lab exam is having someone correctly identify the cephalic artery, but losing partial credit because they forgot to put left, or in this case, right. Don't get the hard part of the question correct and miss the easy part. As I've said,
now will you do
sorry,
will you do the same? Well, I was going to ask if you were going if you'll do the same thing that you were doing at 430 where it was like be specific, like, oh, which one is this? Be specific, and that usually meant left or right.
No, I get where you're going with the muscles when we were talking about multi-headed muscles. So multi-headed muscles, remember, each had their own unique origin and their own unique name. In that case, I used be specific. I shouldn't have to use be specific here for left and right. For putting artery and vein, you should know that you need to put artery and vein. You should know that you need to put left and right when appropriate. So, so yes, don't rely. You won't necessarily see the term be specific on that there for those types of questions because that's something that should be obvious, just like on the bones.
Okay.
All right.
I just remember taking the test on I want to say it was, I can't remember if it was the bones
It was
or the
muscles.
muscles.
It was muscles.
Yeah,
Muscles.
where it was-
We made a point. We made a point of emphasizing that yes, when you heard that, you saw that term, be specific, that the warning bells should go off. But that was specific to the multi-headed muscles, right? I didn't want just bicep brachia. I wanted, long head and short head. I didn't want all of the origins. I wanted the specific origin, the supraglenoid tubercle of the long head. So there, I did that. In this, I shouldn't require that. You should know to put artery and vein. You should know to put left and right. All right.
Professor, I have a quick question.
Yeah.
On the lab manual, I don't know if it's just me, but for my page 526, it's just blank. I have a digital version. I
So-
don't know if that was a typo.
Great question. What the lab manual? So it's less obvious when you have the electronic version, but basically, as we've talked about, there are two different parts to the review: the check your recall and the check your understanding. And the way they've set up the workbook is they want the first page of each part of the review to be on the first page. So if there's an uneven number of pages, then they will leave a blank between the end of the check your recall and the beginning of the check your understanding. And I'm guessing that's what you're seeing.
Got it. Okay, that makes sense.
Yeah, so that's what it is. It's just because from a formatting standpoint, they want both to start on their own pages.
Got it. Thank you.
Yep. Remember also, again, we're done now and I'm happy to answer these questions, but remember, we will also have time at the end of Thursday's class to ask more questions as well. So if you're not prepared with questions, or like I said, if you have content specific questions, we will definitely have time for a review on Thursday as well. That doesn't mean you have to stop asking questions now. You know me, like I said, I love questions. The only bad question is the question not asked. But don't feel pressure. If you aren't ready with questions, then prepare for Thursday and I will have more time to answer them as well.
Professor, you said cephalic artery. Did you mean cephalic vein?
You're right. I did say artery and I meant vein.
Okay, because I was freaking out for a second.
Yes, thank you. No, yes, absolutely. I meant vein. Thank you for catching that.
Thank you.
Yes. Here's what I would say, Claudia. I think the key to this is that I like having lots of different resources because everybody learns differently. And so different tools help different people to be successful. So rather than having one tool that everybody uses, and for some people it's going to work really well, and for some people it isn't, I think it's better as an instructor to provide as many possible resources as possible. And that doesn't even include all the things that, YouTube videos and Google and Quizlets and all the other things that are out in the world that can help you as well. Yeah, it's easy to get overwhelmed by the number of resources that are out there. I think the key for you as a student is to find the ones that work well for you. If you find you're struggling with a resource, then chuck it and go to another one. There's plenty of resources out there. Find the style, find the wording. Again, different flashcards, whether you make them yourself or you buy them. Some people, I'm a very tactile learner. So I like to make my own flashcards because often when I'm recalling the information, I actually recall it from writing the flashcard out as opposed to remembering staring at it when I was waiting in line at Starbucks. Other people don't want to put the time or effort into it, and they work perfectly fine visually studying the flashcards. So I think the key is there is no one way to study this material. There's just the ways that are best for you. So find the ways that are best for you. And if you're not using all of the resources, but you're being successful, then that's awesome. If you're not being successful, then you have the reassurance that there are other resources you can try if they're not helping you. but don't feel that you have to do everything that is out there. Use all the resources, just use the ones that are helping you. And I think I've said this before, but as I mentioned again, the other nice thing about this class, not only that it's hard, so I don't have to be tricky, but the other part about that is, again, my tests, again, this is my opinion. There's people who took me for 430, you'll have to ask them, but I believe my tests to be very straightforward. And the same way I
Very
write this
straightforward.
the same way I
Very
write this
straightforward.
first test is the exact same way I'm going to write every other test that you're going to take in this class. Yes, that is a little bit of an advantage for those who took me from 430 because they already know what to expect. But I already told you to ask them. So please do that. But and again, if you haven't, then go to the discussion board and make a post to ask somebody who took me for 430. But the other thing is this first test, not only is it is important to do well, but it's more important to learn from it. Mathematically, there are enough points in this class where you can get a 0 on your first lab and lecture exam and still get an A in this class. Now, obviously, nobody here should get a 0. And if you got a 0, then hopefully you would have to dramatically change the way you're studying the material. But simply from a math standpoint, it's possible. So what that means is even if you're struggling, even if you struggle on this first exam, if you learn from it, if you learn how I ask tests, how I'm going to grade those, what I'm looking for on the answers, and what worked and didn't while you were studying, you still have time to modify what you're doing to ultimately get the grade you want in this class. So each test isn't all or nothing. You have that opportunity to recover. You have that opportunity to learn. And the more you take my tests, the more comfortable you're going to be with it because my format for them doesn't change. The same way I write the tests, the same way I ask the questions is going to be the same way I do it on every exam you take in this class. All right. Yes. No, I think it says it's 1 point. I don't know if it says 1 question. The short answer to your question is that's not your real exam. If you look closely on the syllabus schedule, I merely have placeholders there for all of the lab and lecture exams. So that first lab and lecture exam thing that you see there is really just a placeholder. It probably won't be till this weekend that I will actually replace it with the actual exams. And honestly, my 430 class has their exam on Monday. So I've got their exam on Monday and you're on Tuesday. So it might not even be till Monday night that I get your real or even heck, because we got noon. I might even be Tuesday morning. Tuesday morning, I may get your exams. But the point will be before noon, real exams will be there. That's just a placeholder I've put there to remind you that those things are coming up, but it's not the actual exam. And the reason is I don't know how many questions are going to be on the lab exam. This first lab exam has a lot of anatomy on it. So it's usually somewhere between 70 and 90 would be my guess. It's going to fall somewhere in that range for this first lab exam. So I don't know how many questions. So that's why you don't have a number there. But the thing that you're seeing right now is just a placeholder. It's not the real exam.
Okay, sounds good. And then does it gonna be timed or we have a certain time to do it, or we say like we have 2 days, or is it limited?
So both are true. You must complete the exams during the class time. So the exams will only be available from noon to 4:35. And within that time, you have a set amount of time to take the exam. So the lab exam may be, again, for simple numbers, an hour and a half. The lecture exam may be 2.5 hours. So notice that's 4 hours for taking a test within the 4.5 hours of the class.
So we won't meet at all. We just take the exam on our own.
Correct. Yep. So all you're doing, yeah. So if everything goes well, you should not hear from me and I should not hear from you. If you have a problem, the first place you should go is to Proctorio's tech support because they're very helpful. And if that doesn't help, then reach out to me and because they can actually do more than I can. So there's that little button to bring up the tech support if you have any issues. So hopefully, again, that's why we had the proctorial quiz, is to make sure you check your proctorial quiz. If you did not scan your area properly, I left you a note on that. So make sure you check that to make sure that if there's any issues, if there's any concerns, please let me know. We need to resolve that before the exam on Tuesday. So yeah, so again, you'll have 2.5 hours, but again, it has to be for instance, for the lecture exam, but it has to be completed during the class time. So if you wait till 4 o'clock to start your lecture exam, you're only getting 35 minutes. Because yes, there's supposed to be 2.5 hours to take the exam, but it must be completed before class ends. So it would at 4:35, you'd get kicked out. So you would only have 35 minutes at that point. So I strongly encourage you to start at the beginning of class at noon. And I encourage you can take the exams in either order that you want, but 90% of the problems that people have, it is with the lab exam. So I strongly encourage you to take the lab exam first, so that if there are some problems, there are times for us to work out those and resolve those issues. And then you've got whatever time you need left to take the rest of the lecture exam. And one last thing, you may have 2.5 hours for the lecture exam. Most people don't take 2.5 hours for that. I give you what I think is an appropriate amount of time plus. So you should get extra time. So you're welcome to take the full time if you want to, but most people don't require the full time. So it usually isn't an issue. All right.
All right, sounds good.
Yep. Any other questions? All right, then I will see you guys on Thursday. Have a good couple days, study hard, and we will finish this off. And again, then come with more questions on Thursday. We'll have plenty of time for review on Thursday as well. I will see you
Thank you,
guys.
Professor.
Thank you.
All right.